Welcome to today's NCLEX RN review session on hemodynamic management. And in this session, we'll focus on recognizing and responding to critical hemodynamic issues affecting perfusion, blood pressure, and overall cardiovascular stability. And so today we will be covering central venous pressure, mean arterial pressure, and cardiac output, also recognizing and managing shock states, hypovolemic, cardiogenic, septic, and neurogenic shock. Also, hemodynamic monitoring devices. We have pulmonary artery catheters, arterial lines, and non-invasive monitoring, and interventions for hypertensive crisis and hypotension. We'll also talk about fluid resuscitation, vasoactive medications, and other priority nursing interventions. And so our goal is to strengthen your critical thinking and clinical judgment so you feel confident answering NCLEX RN questions related to hemodynamic instability and cardiovascular support. And also let us know how you did in this practice test by commenting below. So let's get into our first question. "9 hours following a severe burn affecting half of a patient's total body surface area, the nurse evaluates the patient who weighs 85 kilograms, 180.4 pounds. Which finding should the nurse urgently report to the healthcare provider?" Options: A, clear fluid is seeping from the burn sites. B, the arterial line reads a blood pressure of 96/47. C, over the last 2 hours, urine production totals 45 mLs. D, the cardiac monitor displays a sinus rhythm with a rate of 110 beats per minute. The answer here is letter C. Now, I want you to pay attention to the clues in the question. It said about severe burn affecting half of the patient's total body surface area. That's quite significant right there. So this tells you that the patient has a major burn injury. That's more or less 20% of the total body surface area, and it simply means that resuscitation is very critical to prevent shock in this client. Now, we also have the time frame here of 9 hours following. And so this time actually places the patient in the resuscitation phase, which is basically the first 24 to 48 hours after the burn. And this is the time when the fluids actually shifts and there's going to be fluid losses around this time. Now, take a look into the client's weight of 85 kilograms. So this is a factor in fluid resuscitation calculation. And also you have this phrase stating urgently report to the healthcare provider. So this signals you to create priority assessments. Anything that indicates deterioration or risk of complications. Now, let's analyze about option letter C. Over the last 2 hours, urine production totals 45 mLs. Why is this the correct answer? Well, we know that the urine output is the real-time indicator of organ perfusion during burn resuscitation. And the goal that you should keep in mind, especially for this patient, you have to remember about the urine output that is supposed to be around 0.5 to 1 ml per kilo per hour. So I want you to remember that. So that's 0.5 to 1 mLs per kilo per hour. So this is going to help you in calculating how much should the client supposed to produce urine around this time frame. All right, so now for this client that weighs 85 kilograms, let's give it a try of multiplying it to 0.5 ml. So that's about 42.5 mLs per hour. That is our minimum hourly urine output for this client. If we are using the 0.5 ml per kilogram per hour. All right, so that's 42.5 mLs per hour. And the client's urine output is at 45 mLs. Okay, over 2 hours. So that is basically, actually, that's not 2 hours. That's only, yeah, that's 45 mLs for the entire 2 hours. So that's basically only 22.5 mLs per hour. So that is considered oliguric. And so this is suggesting that there is already hypoperfusion going on, and that's possibly caused by the inadequate fluid resuscitation, or this could signal that the client is developing early acute kidney injury. If it's not corrected, this will lead to shock and also can lead to organ failure. And since the fluid therapy is going to be adjusted based on the urine output, the healthcare provider needs to have this information immediately to modify the IV fluid rate and also to prevent the worsening of the complications. Now, why is letter A incorrect? Well, this basically describes serous exudate, stating fluid seeping, clear fluid seeping from the burn sites. So this is expected in this type of burns due to the increased capillary permeability. And since the patient has 50% total body surface area burns, the fluid loss through the wound is normal and doesn't require urgent reporting unless there are any excessive fluid loss, or let's say any signs of infection, which is not basically mentioned in this question stem. And so while this contributes to the hypovolemia, it's not an immediate priority for compared to the urine output that we have talked about in option C. Now, what about letter B? It's stated about the blood pressure of 96/47 via the arterial line. And this is basically kind of on a low side of the blood pressure, right? And this is not really as significant compared to the oliguria that we are noticing in option C. All right. And here, the patient's blood pressure is somewhat concerning, but the urine output is a better measure of the fluid status. And so if the blood pressure continues to drop, or if the blood pressure falls below, let's say over 90 systolic, then it becomes a bigger concern. All right. And so this is not going to be our best option for this question. Now, what about letter D? The cardiac monitor displays a sinus rhythm with a rate of 110 beats per minute. 110 beats per minute is basically tachycardia, and this is common in clients with hypovolemia, or maybe they're in a lot of pain, also an increased metabolic demand from the injury. And this is mildly elevated heart rate, but it's not a crisis on its own unless it worsens significantly, or maybe it's going to go up into the 140s or the 150s. And this is also an expected finding, but the low urine output that we are seeing in option C is a direct warning sign of under resuscitation. Now, for this next question, I want you to use the airway, breathing, circulation model. And this question is focusing on the circulation and perfusion. And take note that the urine output is the best indicator of perfusion. So this makes the most urgent finding. And again, the blood pressure that we are noticing, of course, this is something that you need to keep monitoring. This is a sign of hypovolemia, but again, this is going to be our next priority compared to the urine output. All right. Now, also, you need to look for the words that indicate severity. The urgently report. This signals that you need to find the most critical issue. And again, the low urine output is the earliest and most reliable sign of fluid resuscitation failure. All right, so let's have number 2. A patient is being treated for hypovolemic shock due to severe dehydration and is currently receiving fluid resuscitation. The following lab results are reported: pH of 7.29, partial pressure of oxygen 80, partial pressure of CO2 at 22 mmHg, and hematocrit 34%. What should be prioritized in the nursing management of this patient? Options: A, administering crystalloid fluids at 200 mL per hour. B, preparing for endotracheal intubation. C, administering sodium bicarbonate. D, administering 1 unit of packed red blood cells. The answer here is letter A. And why is that? Well, when you are managing hypovolemic shock due to a severe dehydration, you got to have to look into the labs as well, right? We have a low pH of 7.29, which indicates that there is acidosis. And the low PaCO2 of 22 normally should be around 35 to 45. This suggests that the client is in acidosis, all right? More likely could be metabolic acidosis in origin due to the dehydration and poor kidney function. And the corrective action here is to continue to provide fluid resuscitation in order for us to restore the circulating fluid volume and to help the kidneys excrete the excess hydrogen ions, which will gradually correct the acidosis. And the crystalloids that we have in letter A, we're talking about possibly lactated Ringer solution or normal saline. These are fluids that are considered first-line treatment for hypovolemic shock because they help replace the lost fluid and also restore the electrolyte balance. Now, the fluids in letter A will improve the perfusion, which is critical for patients in shock, and the rate that we are going to administer at 200 mL per hour is appropriate for an ongoing hydration without overwhelming the patient, so particularly since they already are in shock. Now, what about letter B, preparing for endotracheal intubation? This would only be necessary if the patient was unable to maintain their airway or if they were showing signs of respiratory distress like severe hypoxia or hypercarbia. And in this case, the patient's partial pressure of O2 is 80. So that's basically on the low end of the normal range, right? Within the acceptable range. And there are no signs of respiratory failure or no signs of severe hypoxemia. And so intubation is not priority this time. All right. Now, what about letter C, administering sodium bicarbonate? Why is this incorrect? Sodium bicarbonate is generally not recommended for metabolic acidosis unless the acidosis is severe or life-threatening and the underlying cause is being addressed first. And the issue here is the hypovolemia, the dehydration, which led to the metabolic acidosis. So the fluid resuscitation should be our primary intervention here. And another thing that we don't want letter C as the answer here, it's because sodium bicarbonate can also cause a rapid shift in the pH, and this can potentially lead to alkalosis, which could also suppress the respiratory drive. Okay, so that's why we don't select letter C as our best option. Now, what about letter D, administering 1 unit of packed red blood cells? Now, we know that this is indicated when there is significant blood loss or when the hematocrit is low due to the anemia. And in this case, the hematocrit level is 34%, right? And this is basically kind of slightly on the low side of the normal range. And there is no indication that the patient is anemic or has significant blood loss. So a transfusion is not required this time. And again, look into the hematocrit level of 34%. That is not low enough to require a blood transfusion. Now, for you to answer this question, especially with this hypovolemic shock scenario, you need to identify the underlying cause of the shock, and then you need to prioritize the treatment. And since the patient shock is due to the dehydration, your priority is to restore the fluid volume first, and then you correct the metabolic acidosis. And the strategy here is to focus on the fluid resuscitation first, and then recognize the other interventions like intubation, if there's going to be respiratory distress, bicarbonate administration, if the pH is much more severe than what we are seeing here. And these are not immediately necessary in this case. Let's have number 3. A patient receiving vasopressin for septic shock exhibits which of the following signs that requires urgent communication with a healthcare provider? Options: A, heart rate of 110 beats per minute. B, weak peripheral pulses. C, urine output of 18 mL per hour. D, complaints of chest pain. What is your answer here? That is letter D, complaints of chest pain. So this scenario involves the patient receiving vasopressin for septic shock. Now, I want you to remember that vasopressin is a potent vasoconstrictor. It causes the blood vessels to constrict, and this can increase the blood pressure. However, it can lead to excessive vasoconstriction, which can also reduce the blood flow to the critical body organs, including the heart. And one of the potential adverse effects of the vasopressin is reduced coronary artery blood flow. All right, so reduced coronary artery blood flow. Again, that's the adverse effect of the medication. And so this can lead to myocardial ischemia, and this can trigger the chest pain that the client is experiencing, right? This is a red flag signaling that there is a potential cardiac complication. And the chest pain here is indicating that it is life-threatening, all right? Similar to a heart attack or myocardial ischemia, especially that the patient is receiving the medication. So you need to urgently address this and make sure that it is notified to the medical provider, and so that they can evaluate the client, and so to plan on effective treatment. Now, what about letter A? Heart rate of 110 beats per minute. This is tachycardia. This is common in septic shock due to the body's compensatory response to the low blood pressure and decreased perfusion. And of course, the body is trying to maintain adequate blood flow to the vital organs. Now, we have to monitor this, but this level right now at 110, it does not require urgent intervention on its own unless it is accompanied by signs of cardiac distress, or if there is now hypoperfusion to the vital organs. Now, this is also an expected finding in this case, and again, this is not super high, as if the client is around 140 or 150 beats per minute. And we have letter B, weak peripheral pulses. Why is this incorrect? Well, these are also expected in the septic shock because of the hypotension and the vasodilation. And in addition to that, the vasoconstriction caused by the vasopressin may also affect the blood flow to the peripheral areas. So this can lead to the weaker pulses. And this is also a common sign in shock states, and it does not indicate an acute emergency on its own. And this should be monitored as well, but it does not require the same level of urgency compared to what we are seeing in letter D. Okay, this is pointing to cardiac ischemia. Now, what about letter C? Urine output of 18 mL per hour. That is oliguria, right? And this is a common finding in shock states, including septic shock. And it happens because the body is prioritizing blood flow to the vital organs like the heart and the brain. So there's some kind of shunting of the blood flow. And so there is a reduction in the blood flow to the kidneys here. We know that this is concerning, and this is expected in the early stages of the septic shock. And it does not necessarily require immediate intervention unless it becomes progressively worse. And you have to closely monitor this, but it does not require urgent communication with the healthcare provider compared to the ones that we are seeing in letter D, chest pain. So for you to correctly answer this question, I want you to look for the symptoms that indicate an acute or life-threatening complication. And again, the chest pain is the most concerning because it could indicate a serious cardiac event, which requires immediate action. And always prioritize symptoms that suggest compromise to the vital organs. We know that we are actually dealing with a lot of issues here. Hypoperfusion to the heart, hypoperfusion to the kidneys. But then again, remember that our heart is the powerhouse, right? We have that pump that should be dealt with accordingly. If you don't deal with the pump first, then there's no organ anymore that would be perfusing or pumping the blood into the vital organs of the body. Now, since the client here is receiving the vasopressin, again, remember that this is a vasoconstrictor that can affect coronary blood flow. And again, the client here is experiencing ischemia due to the vasoconstriction of the coronary arteries. All right. Alrighty. So again, I want you to look into the other choices. I want you to think critically. Again, the chest pain that is sudden or that the client is complaining is a signal of a worsening condition. Let's have number 4. When developing a care plan for a patient receiving nicardipine to manage a hypertensive crisis, which intervention should the nurse include? Options: A, help the patient sit up in a chair during mealtimes to reduce risks tied to prolonged bed rest. B, use an automated device to regularly check blood pressure at frequent intervals. C, ensure the patient remains on NPO status to avoid choking if nausea or vomiting occurs. D, schedule tasks to provide the patient with a full 8-hour block of uninterrupted rest overnight. The answer here is letter B. Well, before we're going to go into each item here, I want you to pay attention to the key clues in the question. So the client here is having hypertensive crisis, right? And the client is receiving nicardipine. So the client here is basically having dangerously high blood pressure, and this will require rapid but controlled reduction. Now, I want you to remember about Cardine. This is an IV calcium channel blocker, and so this works very quickly in managing hypertensive crisis. So you need to frequently monitor this client to prevent inadvertent hypotension or inadequate blood pressure reduction. And so this blood pressure medication acts within just a few minutes. And this is going to be titrated based on the blood pressure response. And if the blood pressure drops too fast, the patient risks hypoperfusion to the brain or even shock. And if it remains too high, the client can also develop end organ damage. There's going to be stroke, there's going to be heart failure, there's going to be kidney failure. And according to the guidelines of the American Heart Association, there should be blood pressure monitoring every 5 to 15 minutes when you are going to administer a rapid acting IV antihypertensive such as the Cardine. So you are going to use this automated device to provide real-time recordings and readings for a safer titration of the medication. So that is our best answer. Now, why is letter A incorrect? Well, let's go back into the scenario here that the client is basically having a crisis, and they're typically on bed rest to prevent sudden blood pressure drops with any position changes, especially orthostatic hypotension. We know that the cardipine is a rapid acting a calcium channel blocker. It is also going to dilate the blood vessels. This can lead to dizziness and fainting if the client sits up too soon. And so the priority is blood pressure control, not mobility at this time. Okay. Now, what about letter C? Ensure the patient remains NPO to avoid choking if nausea or vomiting occurs. Now, why is this incorrect? Well, nicardipine is not known for causing any significant nausea or vomiting like the nitroprazide, which is another IV antihypertensive. And nothing by mouth order is not a standard precaution for patients receiving nicardipine. Now, if the patient is not intubated or sedated, there's no need for strict NPO status unless it's explicitly indicated as well. So for you to eliminate this option, go back into the question stem. It does not mention about nausea, vomiting, or aspiration risk. And so this option is not related to hypertensive crisis management. So eliminate this one. Now, what about letter D? Schedule tasks to provide the patient with a full 8-hour block of uninterrupted rest overnight. Well, we know that when a client has hypertensive crisis, they're going to require frequent blood pressure checks. Initially, we're going to do every 5 to every 15 minutes. And then this is really going to lead to impossible sleep, right? And nurses are going to do ongoing assessments, including checking neurological changes to check if there's any other adverse reactions or if there's other complications like chest pain or worsening symptoms. And the monitoring takes priority over sleep in critical care situation. All right. And so for you to eliminate this item or option, remind yourself that the client is in a hypertensive crisis and close monitoring is needed. And so this is much more needed compared to the uninterrupted rest overnight. So unrealistic this time. Okay. So the best strategy in this question is prioritization of the safety. And the most critical intervention is frequent blood pressure monitoring, because the question is involved with this medication, nicardipine. Again, it requires frequent blood pressure monitoring. All right. And so the other options that do not focus on real-time monitoring and medication effects should be eliminated right away. And what about number 5? A male adult patient is brought to the emergency department with a diagnosis of sepsis. As his septic shock progresses, which of the following physiological changes is most likely to occur? Options: A, increased respiratory rate and right atrial pressure. B, increased temperature and urine output. C, decreased systemic vascular resistance and decreased cardiac output. D, increased heart rate and mixed venous oxygen saturation. The answer here is letter D. And why is that? Well, in a case of septic shock, the body undergoes a series of complex changes because it's trying to respond to the infection and also trying to maintain the perfusion into the vital organs. And the increased heart rate is a typical physiological response, right? Now, as the sepsis progresses, the body will activate the sympathetic nervous system, and this can lead to the release of the catecholamines, the epinephrine and norepinephrine, and this will increase the heart rate as part of the body's attempt to compensate for the decreased tissue perfusion, and this will help ensure adequate oxygen delivery to the vital organs. And at the same time, the mixed venous oxygen saturation will also increase in septic shock, which may seem counterintuitive. But the reason for this is, despite an increased heart rate and enhanced oxygen delivery, the tissues are not extracting oxygen properly, and this is due to the inadequate perfusion and dysfunction of the cellular function, right? And so, in other words, the oxygen is being delivered to the tissues, but the tissues are not able to use it effectively. So the SVO2 remains elevated. So this is a hallmark of septic shock. Now, why is letter A incorrect? It states increased respiratory rate and right atrial pressure. Now, This is a plausible change in sepsis due to the hypoxemia, but this is not the most definitive or defining response in septic shock. Now, hypoxemia may increase the respiratory rate, but this is not the primary or most prominent change in septic shock. The right atrial pressure will actually decrease in septic shock because of the vasodilation, and there's also a decreased venous return. So this is basically incorrect. There's no increase in RAP. There is rather a decrease in right atrial pressure. Okay? Because of what? There is massive vasodilation and decreased venous blood return to the heart. Again, the blood vessels are dilating and the fluid also shifts out of the blood vessels into the tissues. And so the blood return to the heart drops significantly. It will decrease the right atrial pressure. Again, this makes the statement incorrect. All right. Now, what about letter B, increased temperature and urine output? The temperature is going to be elevated, and this is common in sepsis because that's part of the body's immune response to the infection. The fever alone results from the sepsis caused by the pyrogens, and this is often seen in the early sepsis. Okay, please take note of that. And in sepsis, urine output tends to decrease due to the poor perfusion to the kidneys. So this is also incorrect. There's no increase in urine output, but a decrease. Decreased urine output. Again, the reason for that is because the kidneys are not getting adequate blood flow from the heart. So again, our urine output here would be less than 30 mLs per hour. Okay. Now, what about letter C? Decreased systemic vascular resistance and decreased cardiac output. So let's talk about the SVR that is decreased. Well, this is true, right? Decreased SVR because of the widespread vasodilation. However, this does not necessarily correlate with a decreased cardiac output in all cases. Okay? Not so. All right? We know that the cardiac output may decrease in the later stage of septic shock, but this is not always the case, right? There is not going to be a decreased CO during the early stage of sepsis. Okay, so early stage, there's going to be a compensatory elevation of the cardiac output. During the later stage, the cardiac output drops. So it's not really just decreased from one stage to the next. No, there is that compensatory elevation of the decreased elevation of the cardiac output during the early stage, rather. And so this statement makes it incorrect. Now, when the shock progresses, the cardiac output, like I have said, it will decrease, but this is not the immediate or defining feature of septic shock. The early stages of septic shock often presents with, let's say, normal cardiac output or even an elevated cardiac output because of the compensatory mechanism. And so the relationship between the SVR and the cardiac output in septic shock can be complex, and it is variable. So this option is less definitive. So we are going to eliminate letter C. So for you to correctly to select the option here, you need to focus on the early compensatory mechanism and what's happening with the blood flow and the oxygen delivery. And I want you to pay attention to the sympathetic nervous system activation, which can increase the heart rate, which is a compensatory response to poor perfusion. And I want you to look for the key phrase that suggests a mismatch between the oxygen delivery and also the oxygen utilization, as you're seeing in option D. All right. And When you identify these key patterns, you can easily spot the correct answer, which is in letter D. And I want you to avoid the less likely choices based on your understanding of septic shock physiology. Now, also prioritize the early signs and the compensatory mechanism. So, because these are actually more likely to be the focus in questions about shock. Now, let's have number 6. A patient in cardiogenic shock is receiving support from an intra-aortic balloon pump. Which observation suggests to the nurse that the treatment objectives are being achieved? Options: A, cardiac output measures 5 liters per minute. B, urine production is 25 mLs per hour. C, stroke volume is recorded at 40 mLs per beat. D, pulse rate registers 110 beats per minute. The answer here is letter A. Why is it correct? Well, going back into the cardiogenic shock, the heart is struggling to pump the blood. It will cause poor perfusion. It can lead to low blood pressure, and it also will lead to organ failure. Now, we're talking about the intra-aortic balloon pump. This is a device that is going to help the heart by inflating during the diastole, and this is to boost the coronary artery blood flow, and this balloon will deflate during the systole. And the reason for that is to reduce the afterload, or it will reduce the resistance the heart has to overcome in order for it to pump the blood. Okay, so again, the balloon will inflate when the heart is in the diastole phase. Okay, and the balloon will deflate during systole. Again, the reason why it has to inflate, and this is supposed to boost the coronary blood flow. Okay, so this will enhance the blood perfusion into the coronary arteries, while it's going to help deflate during the systole. So this will decrease the systemic vascular resistance, SVR. So when it does that, it will reduce the amount of energy the heart has to work on, because there is decreasing systemic vascular resistance. And so the main reason for the IABP is to increase the cardiac output. That is the main goal. This is to help stabilize the patient and also to restore proper organ perfusion. Now, why is option A the correct answer? Well, take a look into the value of 5 liters per minute. That's well within the normal range. This is what we want in this client. Okay, again, the cardiac output is the total amount of blood that the heart pumps per minute, and this is obtained by calculating the heart rate by the stroke volume, which is the amount of the blood pumped with each heartbeat. And in the cardiogenic shock case, the cardiac output drops well below the normal, often below 3 liters per minute. So I want you to remember about the cardiac output. This is basically the product of the heart rate and the stroke volume. Okay. Again, in the client with cardiogenic shock, the cardiac output can drop as low as less than 3. All right. Now, so the 5 liters per minute is indicating that the heart is pumping enough blood to meet the body's needs. So it simply means that the device, the IABP, has helped restore the normal function of the heart, and this is what we want. Okay. Now, what about letter B? Urine production is at least 25 mLs per hour. Now, take a look into the number 25. That's way below the lower limit. All right. So 30 mLs per hour is our minimum in adult. Okay. So this is already considered as oliguria. And this means that the kidneys are not getting enough blood and oxygen. And go back into the question here. It's asking, it said, which observations suggest to the nurse that the treatment objectives are being achieved? So this alone is not a good reflection that there is good cardiac output. That's 25 mL per hour. That's low. Okay. Now, what about letter C? Stroke volume is recorded at 40 mL per beat. Now, what is stroke volume? This is the amount of blood the heart pumps with each beat. And the normal stroke volume supposedly is around 62 to about 100 mL per beat. So this is very low, 40 mL. And this indicates that the heart is not pumping as efficiently as it should. Now, we know in cardiogenic shock, the heart is struggling to generate enough stroke volume. And so the intra-aortic balloon pump should help increase the stroke volume by reducing the afterload. Now, what about letter D? Pulse rate registers 110 beats per minute. This is tachycardia, right? So this simply means that the heart is working harder to compensate for the low cardiac output. Now, we know that in shock, there is that compensatory response. So the heart is trying to speed up to try to increase the blood flow and to make up for the poor perfusion. Now, if the intra-aortic balloon pump is working, then it should be helping to improve cardiac output, and it should maintain a rate that is within the normal range, not tachycardia. So the 110 beats per minute is suggesting that the shock is still ongoing and the intra-aortic balloon pump has not yet achieved its goal of improving the cardiac function. And so when you answer this type of question, I want you to look for the key indicators of shock and recovery. And again, in cardiogenic shock, we want to see improvement in the cardiac output. There should be improvement in the urine output, improvement in the heart rate, and you need to focus on what the question is really asking. So what indicates the treatment objectives are being achieved this time? All right. So I hope that you're getting this test question correctly. Let's have number 7. The nurse is caring for a patient who has been admitted for an exacerbation of heart failure and is concerned that the patient might be transitioning into shock. What should the nurse prioritize in planning care for this patient? Options: A, administration of intravenous fluids; B, administration of packed red blood cells; C, administration of dopamine; D, administration of whole blood. The answer here is letter C. And why is that? Well, the client in this case is having an exacerbation of heart failure, which raises the concern of cardiogenic shock, right? So the heart is unable to pump effectively. So this can lead to a poor perfusion to the vital organs. Now, again, the primary concern of the cardiogenic shock is restoring the heart's pumping ability rather than simply increasing the blood volume. Okay. Now, dopamine in option C is an inotropic agent. So what does that mean? It simply means that this drug can increase the cardiac contractility. That is the main purpose of this medication. And this is going to improve the force of the pumping ability of the heart. So this will allow better heart function. It will improve the cardiac output. Now, in addition to that effect, the dopamine can also cause vasoconstriction. And when it happens, the blood pressure will somewhat be close to the normal and hopefully be stabilized. And so this action in letter C is very critical in managing the underlying issue. To improve the cardiac output, it will also improve the perfusion without overloading the patient with excess fluids. And The issue here in this client, the client has heart failure, right? There is no problem with hypovolemia. The main problem here is the decreased contractility of the heart muscle. That is our main issue here. And so we want to improve the contractility in order to achieve better cardiac output. Now, why is letter A incorrect? Administration of intravenous fluids. We know that the IV fluids is very important in treating other types of shock, right? However, this client has exacerbation of heart failure. The heart is not able to effectively pump the circulating blood volume. So if we are going to administer fluids here, this is going to worsen the problem, okay? And this will lead to pulmonary edema. We don't want this in this patient. Again, this can lead to accumulation of the fluid into the client's lung. It will worsen. It can compromise their oxygenation and their breathing. We don't want to increase fluid volume in this patient. All right? Do not increase fluid volume. Okay? There is no issue with dehydration in this CHF exacerbation. That's why A is incorrect. Now, what about letter B? Administration of packed red blood cells. This is typically reserved for clients where they have anemia or they have acute blood loss, but neither of which are directly implicated in this case. And we know that cardiogenic shock is due to the heart failure exacerbation. It does not involve blood loss. So this option is not going to help address the issue. Now, what about letter D, administration of whole blood? This is quite similar to letter B, so this is also incorrect. This is indicated for those clients with severe blood loss. All right? And our case doesn't talk about severe blood loss here. It makes this option incorrect. Again, our issue is the decreased pumping ability of the heart muscle, not about fluid volume, not about red blood cell volume. So we don't need letters A, B, and D. Again, your critical strategy here is to focus on the underlying cause of the shock. Again, we are talking about cardiogenic shock, and the issue is not about the lack of the volume. Okay? There is a problem in the effective cardiac output. That is our main concern here. Decreased cardiac output. And the reason? There is decreased myocardial contractility. And so when you are asked to prioritize care, you got to focus on treatments that directly address the heart's function rather than volume expansion or the blood products. And so we don't have any option than letter C. Dopamine is an inotropic agent. This is going to enhance the cardiac contractility. It will help raise the blood pressure without causing fluid overload. All right. So you have to pay attention to the context. This is a patient with heart failure exacerbation, and this is often a precursor to cardiogenic shock. Let's have number 8. When the low pressure alarm triggers for a patient with an arterial line in the left radial artery, what steps should the nurse take? Options: A, evaluate the patient for irregular heart rhythms. B, inspect the left hand for signs of paleness. C, quickly flush the arterial line system. D, recalibrate the monitoring device to 0. The answer is letter A. Okay, and why is that? The low pressure alarm on the art line, this basically suggests that the patient's blood pressure has dropped significantly. Okay. Blood pressure. It states low pressure alarm. Okay. And this is going to be one of the most critical causes of the sudden hypotension. Okay. And most often this is a dysrhythmia. Now, With irregular heart rhythms such as bradycardia, ventricular tachycardia, or maybe complete heart block, this can severely cause a reduction in the cardiac output, which can lead to the drop in the blood pressure. And so your first action should be to check the cardiac monitor or to perform an EKG to see if an arrhythmia is present. Okay. Again, the drop in the blood pressure is caused by maybe an arrhythmia. And again, this can be a life-threatening issue. It could be a ventricular fibrillation or maybe a systole. And we need to immediately intervene. Maybe the client needs pacing, or maybe we need to administer medications, or we have to defibrillate the patient maybe because they are in VFib, right? And this is done to directly address a life-threatening issue, and this is the best response. Now, why is letter B incorrect? Inspect the left hand for signs of paleness. Well, it's true that an arterial line in the radial artery can also lead to the complications like thrombosis or maybe occlusion, which may cause hand ischemia, leading to the paleness, or maybe coolness or poor capillary refill. But an occlusion would more likely trigger a high pressure alarm. Okay, so this is pertaining to occlusion, but this occlusion will lead to high pressure alarm, not low pressure. And so this is not coinciding with what's we are reading in the scenario. So this is going to be an incorrect option. All right. What about letter C? Quickly flush the arterial line system. Why is this incorrect? Well, flushing the arterial line is helpful if there is going to be a clot, if there is an air bubble, or maybe dampened waveform, which can interfere with accurate readings. But the question does not mention a blocked or dampened waveform, just the pressure is low. And so flushing does nothing to fix the actual drop in the blood pressure, which could be due to the shock, or could be a dysrhythmia, or maybe another systemic issue. And so for you to eliminate this option, look back into the case scenario. There's no indication that the issue is due to a blocked or maybe a malfunctioning line. And so flushing is an inappropriate first response in this question. Now, what about letter D? Recalibrate the monitoring device to 0. So this is done when the reading seems off, or maybe it is inconsistent, but this is it's not going to be done when there is a clear or alarming trend in the patient's blood pressure. And since the low blood pressure or the low pressure alarm likely reflects a real drop in the blood pressure, then if you're going to re-zero or recalibrate, then this can delay the necessary assessment and intervention. Okay, so this can delay assessment and intervention. Okay, so if the reading were false, there would likely be other signs such as normal, non-invasive blood pressure measurements, or a sudden change in the waveforms. And also, I want you to eliminate the other incorrect options. And again, the STEM does not suggest a misreading or inaccurate equipment. It suggests an actual drop in the pressure, which demands immediate patient assessment over the calibration. Okay, so for you to correctly answer this question, I want you to prioritize. Again, the low pressure alarm suggests hemodynamic instability, which could impair oxygen delivery to the vital organs. And the airway and breathing are stable in this scenario, so circulation or the blood pressure takes priority. And you got to eliminate those distractors that do not address the core issue. Okay, so the flushing of the art line or recalibrating are actually focusing on equipment problems rather than the patient's underlying condition. And so when the question presents an abnormal finding, assume it's real unless you're told otherwise. And again, the low pressure alarm is our main clue in this question. Do not miss this phrase. Let's have number 9. A patient when shocked presents with CVP of 2 mmHg and a mean arterial pressure of 60. Which action should the nurse prioritize based on the prescribed treatment? Options: A, increase the flow of oxygen. B, request arterial blood gas analysis. C, insert a urinary catheter for monitoring. D, administer additional IV fluids. The answer here is letter D. And why is that? Well, the patient's CVP of 2 is on the low side, okay? And I want you to remember about the range here. The range can be around 2 to 8 mmHg. Even though it's quite within that range in the critical care, right? It's on the low side, and it simply means that our client is probably having low fluid volume. And also the MAP of 60 is also concerning because it is below the desired threshold for adequate perfusion. Generally, MAP is supposed to be around greater than 70. In some textbooks, they would say greater than 65, right? So that would be our cutoff. And so the most pressing issue in this question is we are dealing with a client that has shock, and we need to improve the circulating volume to stabilize the blood pressure and also to improve the tissue perfusion. And this can be effectively achieved through the administration of IV fluids. Now, the priority here is to, again, expand the volume of circulating fluid in the system. It will raise the MAP, and also it will increase the overall perfusion. And so letter D alone can directly address the primary issue, which is the hypoperfusion. Again, this would be our first line treatment. What about letter A? Increase the flow rate of oxygen. We know that oxygen supplementation is going to be critical as well to help improve oxygen delivery to the tissues, but it is not the first priority when your primary problem is low circulating volume. There's low blood pressure. And increasing the oxygen flow rate might be helpful, but it does not address the underlying issue of low perfusion caused by the inadequate volume. And the fluid resuscitation is the needed intervention to stabilize the client's hemodynamics this time. Now, what about letter B? Request arterial blood gas. This is also useful in assessing the patient's oxygenation and acid-base balance in shock. But in this case, it's not the most urgent intervention. Your priority is to stabilize the patient's hemodynamics. We have an issue with circulation. Okay, so this is going to be the arterial blood gas analysis will be our second priority after we have addressed the hypovolemia the client is having. All right. And what about letter C? Insert a urinary catheter for monitoring. We know that this is also a valuable means of monitoring the client's urinary output and also to monitor the renal function, but it is not going to address the issue of hypoperfusion. Your priority here is to restore circulating volume and to raise the blood pressure. And you have to deal with the insertion of the urinary catheter once you have already initiated the IV fluid boluses. Okay, and so when you encounter this type of question, especially with hypovolemic shock or sepsis, you remember that fluid resuscitation is usually the first step. And shock can lead to hypoperfusion, which means the body tissues are not receiving enough blood and oxygen. And restoring the circulating volume via IV fluids is typically the priority because it directly supports the blood pressure and tissue perfusion. And this should be your immediate action in this case. Now, what about number 10? A male adult patient presents to the emergency department with chest pain and difficulty breathing. He has a medical history that includes hypertension, coronary artery disease, and ischemic cardiomyopathy. The patient reports that he ran out of his medications last week. Upon admission, his vital signs are temperature 37 degrees Celsius, heart rate of 64, respirations 38, blood pressure 220/125. His physical exam reveals bibacillar rales and saturation of 84 on room air. Which medication would be the most appropriate choice to manage his elevated blood pressure? Options: A, nicardipine, Cardine; B, sodium nitroprusside or nipride; C, IV hydralazine, apresolin; D, labetalol, normodine. The answer here is letter A. That is the nicardipine. Now, going back into nicardipine, this is a calcium channel blocker. Right? So this is going to work by relaxing the smooth muscles of the blood vessels. This is going to help lower the blood pressure, and this is a rapid acting antihypertensive medication. And given with the patient's underlying condition, there is ischemic cardiomyopathy. Go back to here. All right. There's also coronary artery disease. That's a significant history. And also, the nicardipine has that property. It is selective, and it has the ability to control the blood pressure in hypertensive emergencies. So this is the best option here. Now, what about letter B, sodium nitroprusside? Why is this incorrect? We know that this is also effective for lowering the blood pressure, but this is reserved for more severe hypertensive emergencies. And also, you have to exercise caution, especially if the patient may have renal or liver diseases. So again, this is going to be used for more severe hypertensive crisis. Okay. Again, you have to watch out for liver, renal malfunction. So if the patient has these conditions, then they're probably not going to be the best, or they're not going to be the best medication for this type of patients, right? And along with that, the nipride can also cause cyanide toxicity if it is going to be used in higher doses. So you got to watch out for that one as well. Cyanide toxicity with higher doses. Again, this is not our best or primary option for this hypertensive crisis. Now, why is letter C an incorrect option? Hydralazine, apresolin. And this is an antihypertensive drug that is often used. We know that this is a vasodilator, but it doesn't provide the same precise titration of the blood pressure as nicardipine. And this is less ideal in hypertensive emergencies because of its short duration of action. And another thing is that it can cause reflex tachycardia. Reflex tachycardia. And another downside is that it has short duration of action. So this would not be the best modality or treatment in treating the client's hypertensive crisis. All right. Now, what about labetalol or normodine in letter D? So this is a medication that is classified as a beta blocker, non-selective beta blocker. And we know that this can be effective in lowering the blood pressure, but it is contraindicated in clients with heart failure. The reason is that the beta blocker labetalol can decrease the heart rate, and it can also decrease the contractility of the heart. Especially that the client has this long-standing history of heart failure. There's also ischemic cardiomyopathy. So again, this can lead to bradycardia. This can lead to decreased contractility. Not the best option for a client with a heart failure and ischemic cardiomyopathy. And look into the patient's heart rate of 64 beats per minute. If you're going to give that labetalol, it would go down some more. So not the best option here. And when the client is in a hypertensive crisis, it doesn't mean that it just doesn't require one IV push. The client will require several doses of the antihypertensive medication. And again, this can worsen the client's cardiomyopathy because of the decreasing heart rate and decreasing contractility. So when you see this type of question, especially with a hypertensive crisis, you have to focus on the patient's underlying condition. Now, if the patient has a history of heart disease or heart failure, you need to be cautious with the medications that you are supposed to administer. You probably have to question what the medical provider has ordered. All right. Now, also the medications that you are going to administer, make sure that you have to administer that drug that can allow you to titrate the drug precisely and are also cardiac selective, like nicardipine. And don't neglect into looking the medical history, which is very important for you to eliminate those incorrect options. So I hope that you got this test question correct this time. 11. While assisting with the insertion of a pulmonary artery catheter, how does the nurse confirm correct placement when the balloon is inflated? Options: A, pattern reflecting systemic arterial pressure. B, waveform typical of pulmonary artery wedge pressure. C, standard pulmonary artery pressure tracing. D, graph of system vascular resistance. The answer here is letter B. That is the waveform typical of pulmonary artery wedge pressure. Now, you probably have forgotten about what this modality is: pulmonary artery pressure catheter. So this is basically a catheter that is also known as the Swan-Ganz catheter. So the purpose of this catheter is to measure the pressures within the pulmonary circulation, and it will also assess the hemodynamic status. Now, the goal of this device during the insertion is to ensure that the catheter is positioned correctly in the distal branch of the pulmonary artery, which is basically right here. Now, so during the insertion, the catheter basically has that balloon inflated, right? So this balloon is going to be inflated to make sure that this is going to float through the right atrium. And also it will pass through the right ventricle and into the pulmonary artery. So again, the balloon is inflated to allow it to float around those narrow passages and the chambers. Now, when it reaches into the distal portion of the pulmonary artery, right here, let me enlarge that one. So when it reaches into the farther end of the pulmonary artery, the catheter will actually occlude the forward blood flow. So remember that this is the pulmonary artery, right? And so the balloon will actually occlude that forward blood flow. And around this time, when it occludes, the pressure measured by the pulmonary artery wedge actually reflects the amount of pressure that is going to be monitored here. And so the waveform that you should be seeing once the balloon or once the catheter has occluded this distal section of the pulmonary artery, there is this classic low amplitude. There is that smoother pattern that confirms that there is now proper placement of the catheter. Okay. And once the measurement has been obtained, the balloon is going to be deflated in order to restore the normal blood flow. Okay, we don't want to keep the balloon inflated the whole time. Again, once you get that reading, once you see that low amplitude reading for the pulmonary artery wedge pressure, the balloon is going to be deflated, and there's going to be resumption in the measurement of the pulmonary artery pressures. Okay. Now, why are the other options incorrect? Okay, so letter B is correct, letter A is incorrect. Pattern reflecting systemic arterial pressure. Why is this incorrect? Well, the systemic arterial pressure is referring to the blood pressure in the aorta, in also the large systemic arteries. Okay, so this is referring to the pressure in the aorta, not pulmonary artery. Okay, it also measures the pressure in the large systemic arteries. Okay, now again, I want you to go back into the purpose of the pulmonary artery catheter. The purpose is to measure the pressure, the pulmonary pressure. It will measure pulmonary pressures and left-sided heart function. That is why letter A is incorrect, because this systemic arterial pressure is basically measuring the pressure in the aorta and the systemic great blood vessels. Now, what about letter C? Standard pulmonary artery pressure tracing. Now, once the catheter is properly placed and the balloon is deflated, the device will now monitor the standard pulmonary artery pressure. So it will show systolic, diastolic, and also the mean pulmonary artery pressure. However, during the balloon insertion, right, we're talking about the insertion here. The catheter will temporarily occlude the pulmonary artery branch. So this will eliminate forward blood flow. And this changes the waveform to the pulmonary artery wedge pressure rather than the usual pulmonary artery pressure tracing. So again, this is basically what we're going to be doing once everything has been completed, right? So that makes it incorrect. Now, letter D, graph of systemic vascular resistance. Why is this incorrect? The graph of SVR is representing the resistance to the blood flow in the systemic circulation, and this is a calculated value, not a waveform. Now, the pulmonary artery can help obtain the data to calculate the systemic vascular resistance, but it does not display the systemic vascular resistance as a direct measurement. Okay, and so the clue to eliminating option D is that the SVR is not a visible tracing on the monitor. Not a visible tracing. It's rather calculated using formula. So this option does not apply. All right. So for you to correctly answer this test question, I want you to look for the key phrase, when the balloon is inserted. Okay. We are in the process of the insertion. So this signals that the question is about pulmonary artery wedge pressure, not general pulmonary artery pressures. And I have to remind you to eliminate those answer choices that do not really fit the catheter's purpose. Again, with letter A, systemic arterial pressure, this relates to the systemic circulation. This is the pressure that you can find in the aorta. And letter D, the vascular or the graph of systemic vascular resistance is basically not a value that you can see in the monitor. This is rather a calculated value. Okay, so when you are going to be encountering this type of question, when there is a scenario of, let's say, pulmonary catheter insertion, there should be, you have to look into the case about the correct positioning, that there is confirmation that the balloon has already been in the distal end of the pulmonary artery. Okay, so this is going to be confirmed when the inflated balloon produces that pulmonary artery wedge pressure waveform. Okay, don't forget about that photo that I showed you earlier, that low amplitude waveform, as a confirmation that the balloon has already occluded the forward blood flow. And so once that is confirmed, the balloon is going to be deflated. 12. A nurse is caring for a client with cardiogenic shock who is receiving a dopamine infusion. Which actions should the nurse take? Select all that apply. Options: A, administer the medication using a wide tubing in conjunction with a 0.9% normal saline. B, avoid administering any alkaline solutions in the same line as dopamine. C, monitor the client's lung sounds, vital signs, and hemodynamic status. D, inquire about the presence of an advance directive or durable power of attorney for healthcare decisions. E, aspirate the injection site to prevent injecting directly into the vein. This is a select all that apply. We have multiple answers here, and those are letters B, C, and D. So B said, avoid administering any alkaline solutions in the same line as dopamine. And dopamine is a sympathomimetic drug, and this can stimulate many receptors to improve the heart function and also improving the heart, or the blood flow rather. However, it is incompatible with the alkaline solution. So we're talking about sodium bicarbonate. And when you are going to administer the dopamine with alkaline containing fluids, this can lead to precipitation. Okay? Incompatibility with alkaline. So this can lead to precipitation. And this could block the line, and it will reduce the efficacy of the medication. So your clue here, alkaline solution, it's a big no-no. Avoid mixing this with dopamine. Now, what about letter C? Monitor the client's lung sounds, vital signs, and hemodynamic status. Well, we know that dopamine infusion will require continuous monitoring of the client's condition, especially in the critical care settings, especially that the client has cardiogenic shock, right? So the frequent monitoring here is very critical because dopamine affects the cardiovascular system, and you want to have to monitor the vital signs more frequently, right? In order to check for any abnormal lung sounds, especially this is going to reflect that there's probably fluid buildup in the pulmonary tree. So this will enable you to identify if maybe the client is having complications with pulmonary edema. And also, the client will require frequent monitoring of their hemodynamic status in order to ensure adequate tissue perfusion and organ function. And so the key word here is continuous monitoring, which will help catch any complications early. So that's why that's one of the correct answers. Now, what about letter D? Inquire about the presence of an advance directive or durable power of attorney for healthcare decisions. While it isn't directly related to the medication, but it is also a critical part of our care to ensure that decisions will align with the patient's wishes in case their condition can worsen. And in a case of cardiogenic shock, the situation can change rapidly. And so it is very important for us to know whether there is an advance directive or maybe a pulsed or a directive for end of life care. And so the clue here is critical situation. So it is very important for us to know the patient's wishes in cases of a life-threatening event. Again, in a case of cardiogenic shock, this is very fluid. Anything can happen. The patient might not come around. And also we have letter A as one of the incorrect options here. It said about administer the medication using a white tubing in conjunction with a 0.9 normal saline. Well, the white tubing is typically used for blood transfusions or administering multiple fluids at the same time. And again, dopamine should not be administered through a white tubing. This is gonna require its own dedicated IV line to prevent any interaction with other fluids or medication. So when you think about dopamine, think about avoiding incompatibilities. So there should be dedicated IV line. So that is our safeguard. We don't want to mix or administer any other medications through that line. Okay. Now, what about letter E? Aspirate the injection site to prevent injecting directly into the vein. Why is this incorrect? We know that aspiration is important when injecting subcutaneous or intramuscular injections to check if you're in the blood vessel. But with dopamine, this is administered intravenously, so there's no need for you to aspirate the site. And so the clue here is IV dopamine administration. All right. So I want you to pay close attention to the specifics of the medication administration, whether it's intravenous, intramuscular, and also to consider the complications, the compatibility issues with the other solution. And in this question, dopamine requires a dedicated IV line, and it is incompatible with alkaline solution. Okay. That's how number 13. While monitoring a patient with an arterial line in the right radial artery, which observation prompts the nurse to intervene? Options. A, the flush bag and tubing haven't been replaced in the past 48 hours. B, the flush system infuses 3 ml of solution hourly. C, the right hand feels colder and compared to the left hand. D, the mean arterial pressure registers at 77 mmHg. The answer here is letter C. The right hand feels colder compared to the left hand. Now, before we go into discussing about the options, let's go into the art line topic here. And so the art line basically is a thin catheter that is inserted into an artery, and it's commonly inserted into the radial or maybe a femoral artery. And the reason for this art line is to continuously monitor the blood pressure in real time, and this will also allow for the nurses to draw arterial blood samples without repeated needle sticking. And so the question here is, how does the art line works? Well, the catheter is going to be inserted into the an artery to and also connected to the pressure tubing, and there is that pressure system. Okay, so there is that flush solution. So you're seeing here a bag of saline, heparinized saline, I should say. So this is basically maintained under pressure. This is pressurized in order to prevent clotting and backflow of the blood. Now there's also that transducer right here. Okay, so this is going to be connected to the monitor. It will convert the arterial pressure into the into electric signals, which are all going to be displayed into the monitor, showing different waveforms, and also will give us numeric blood pressure readings on the monitor. Now, take note that this art line will also require that 3-way stopcock. All right. So this is going to allow the nurses to do some collection of blood samples, maybe arterial blood gases. Now, there's also that fast flush device, which is going to help clear the system of air bubbles or clots. Now, the key points here in our arterial line is that it can provide us continuous blood pressure monitoring. This is very ideal in critically ill patients, and this will allow us to frequently check the arterial blood gas because we can draw blood samples through that one. However, you're not supposed to administer medications through the ART line. And another thing that you need to remember about the ART line is that you need to keep the transducer at the phlebistostatic axis. Okay, so I hope that you remember this concept. Phlebistostatic axis. And this is basically on the fourth ICS mid-axillary line, okay, on the left, okay? And since the catheter is inserted into an artery, the right radial artery, and so you as a nurse here must closely monitor the circulation to the hand. Okay, so let's go back into the question here. Why is letter C the answer? Okay, again, the catheter is inserted into an artery, usually the right radial artery, and so you have to closely monitor for the circulation to the hand to prevent complications like ischemia, possible thrombus formation, or maybe arterial occlusion. And the question is asking which observation requires intervention. And when the client's hand feels colder compared to the left hand, this basically reflects that there is decreased blood flow to the right hand, which can lead to serious tissue damage if we are not addressing this quickly. Now, again, the ART line can be easily occluded, could be a blockage, or there could be maybe an issue with a vasospasm or maybe a thrombus formation. And again, the first signs of impaired circulation are decreased temperature. Okay, so let me list it down. Decreased temperature. There's going to be pallor, and there's also decreased cap refill on the involved extremity. And there's also weak or maybe absent pulses. So these are the things that you need to keep an eye for this patient that has the ART line. So if you're not gonna immediately intervene this can lead to ischemia, can be a problem. This can lead to tissue necrosis, right? So let's take a look into letter A. The flush bag and tubing haven't been replaced in the past 48 hours. Is this a bad thing? Well, it is not, because with the arterial flush system, this should be changed every 96 hours. Basically, that's about 4 days, right? 4 days. So past 48 hours is not yet overdue. So not the best option here. It's still within the time frame. Now, what about letter B? The flush system infuses 3 ml of solution hourly. Is this a bad thing? Well, the ART line require a slow, continuous flush, usually around 3 to 6 mLs per hour. Okay? 3 to 6 mLs per hour, and this is to keep the line open. We're talking about the ART line, not a venous axis. And the reason for this is to prevent clot formation. And the 3 mLs is within the standard flushing procedure. And we have letter D, the mean arterial pressure registers at 77 mmHg. 77 is basically a normal MAP. So if you forgot about what MAP is, this is basically the measurement of the pressure that will tell you that the body or the heart is still able to perfuse blood into the organs. Okay, and for you to calculate the MAP, you have to recall that this is obtained through obtaining the systolic blood pressure. And so you are going to basically multiply the diastolic blood pressure by 2, and then you're going to add it to the systolic blood pressure, and you divide it by 3. Okay, and normally the MAP should be greater than or equal to 65 or greater than 70. Okay, and a value of 77 is well within the normal range. Okay, now for you to eliminate this option, again, recall the normal MAP. So I want you to go back into the question stem and also evaluate the different options here. You have to pick this up here. Prompts the nurse to intervene. So basically, this is signaling you that one of these observations indicates serious complications that require immediate action. Now, if there is going to be a change in the circulation, which is basically manifested in letter C, there is an issue with circulation to the site. Okay, there is perfusion issue, then this should concern you. Okay, this can lead to complications and neurological dysfunction, or let's say neurological or motor function of that extremity if you're not going to intervene right away. And this is basically a compromise of the vascular function to that hand. And if you are going to ignore this, then this can lead to permanent tissue damage and even loss of the limb. Remember that this is an arterial blood vessel. Okay, and again, go back into the other options. You have to recall the standards of when to replace the flush bag and how much solution is supposed to be flushed hourly, and also to recall the mean arterial pressure. And so this will help you eliminate those things. Now let's have number 14. A nurse is about to begin administering a dopamine infusion at 3 micrograms per kilogram per minute to a client who has just been successfully resuscitated. The client is currently receiving lidocaine 2 milligrams per minute through an existing IV site. What is the nurse's next step when setting up the dopamine infusion? Options: A. Prepare for the healthcare provider to insert a subclavian line for the dopamine infusion. B. Administer the dopamine infusion via the lidocaine IV tubing. C. Clarify with the healthcare provider that dopamine should not be administered with lidocaine. D. Initiate a separate IV line to administer the dopamine infusion. The answer is letter D. Remember about the dedicated line that we need to do for dopamine infusion. And dopamine is incompatible with many other IV medications, including lidocaine, which is already being administered through the existing IV line. And again, if there is incompatibility, think about the precipitation, which I already mentioned earlier. We don't want this in this patient. Okay, so this can reduce the efficacy of the medication, efficacy of the lidocaine, efficacy of the dopamine, and we don't want that. And so we need to have a separate IV line for us to administer the dopamine. Again, remember about the risk of incompatibility. It has to be run or infused into its own line. And for you to also get acquainted with the dopamine infusion, since we are administering here a dose of 3 micrograms per kilogram per minute, this is basically a dose that is allowable in a peripheral IV access. Okay, so this is considered as a low dose dopamine administration. Okay, so the dopamine here is primarily administered to act on the dopaminergic receptors. This can promote the renal and mesenteric vasodilation without causing a significant vasoconstriction. So this is safer for a peripheral vein infusion. However, if higher doses is going to be required, typically greater than 5. So let's say greater than 5 micrograms per kilo per minute, then that is already considered as higher dose. So this will require central line. Okay. Again, our case scenario talks about the low dose dopamine infusion. Peripheral IV line is appropriate. Okay. Now, whenever there is going to be an issue, especially if we are going to have, let's say, an error of administration. Let's say you administered a dopamine in high dose into a peripheral IV. This can lead to extravasation. Okay, so extravasation is going to be a risk whenever you're going to be administering dopamine via PIV, high dose. So it's never advisable to administer high dose dopamine via the peripheral IV access. Again, it can lead to extravasation. It can lead to tissue necrosis. So that's not what we want in this client. Now let's go into option A. Prepare for the healthcare provider to insert a subclavian line for the dopamine infusion. Is this really needed? Well, it's not necessary just because dopamine is being administered. You can establish that IV access yourself with a peripheral IV. So as long as you are not mixing medications, you are safe to go. Again, it's stated about inserting a subclavian line for the dopamine infusion. This is not necessary in this case. We are administering a low dose dopamine. Now, what about letter B? Administer the dopamine infusion via the lidocaine IV tubing. This can lead to precipitation. It is incompatible. We don't want this. Now, what about letter C? Clarify with the healthcare provider that dopamine should not be administered with lidocaine. Do we have to clarify? This is not necessary. There's no need to clarify the order with the healthcare provider because the solution is already straightforward, right? We know that this is incompatible, and you can look it up in the drug handbook. So you have to establish a new IV line for this case, all right? There's no need for this step because the answer is simple. Use a separate line. So I hope that you're catching on to the administration of dopamine. Let's have number 15. A patient with no prior heart issues or swelling arrives at the emergency department experiencing sudden breathing difficulty. He's intubated immediately and handed over to your care in the ICU. Initial tests show a 12-lead ECG with a rapid sinus rhythm at 130 beats per minute, occasional extra-atrial beats and ST segment depression, CPKMB at 5%, troponin at 0.1 nanograms per ml, and BNP of 758 picograms per ml. These results most strongly suggest options: A, tricuspid valve dysfunction, B, inflammation of the pericardium, C, heart attack with shock from cardiac nature, or cardiac failure rather, and D, sudden onset of heart failure. Alrighty, let's have a review of your patient's labs. BNP of 758, that's elevated. Take a look into the sinus rhythm at 130 beats per minute. There is rapid sinus tachycardia here. There is also ST segment depression. CKMB at 5%, troponin at 0.1 nanograms per ml. The correct answer here is letter D. And why is it sudden onset of heart failure? Well, you have to recognize that 758 picograms per ml is well above the 100 picograms per ml. And in most cases, we are going to have to use this value, right? That is our cutoff. Normally, anything that is above this 100, it is a red flag that the client is having CHF, right? So that is a BNP, the brain natriuretic peptide, which is going to be released when the heart struggles to pump effectively, especially in this case. So this basically suggests that the client is having heart failure. This is the best indicator lab result for this case. All right. Now, why is letter A incorrect? Tricuspid valve dysfunction. Why is this incorrect? Well, the tricuspid valve is on the right side of the heart. If it were severely dysfunctional, we would expect right-sided heart failure symptoms like peripheral edema. There's going to be jugular venous distension. There's going to be liver congestion. But we don't see this in our case scenario. So if there is dysfunction, this is going to cause right-sided heart failure. And the manifestations that we should be seeing in the case, but we are not seeing them, there's going to be positive JVD. There's going to be peripheral edema. There's going to be ascites, and also the liver congestion. All right. So this doesn't really match with our case. So eliminate that one. Now, what about letter B, inflammation of the pericardium? Why is this incorrect? We know that pericarditis presents with chest pain, right? It is going to be relieved by sitting up and leaning forward. And there's also pericardial friction rub. There's going to be diffuse, widespread ST elevation on the ECG. Okay, let me write those down. Okay, when there is going to be inflammation of the pericardium, you will see widespread ST elevation. There's also going to be pericardial friction rub. When you are auscultating the client. And another thing is that the pain basically is going to be relieved. Chest pain relieved when the client sits up. And also when they are leaning forward. Okay? Chest pain goes away when they lean forward. And take a look into the ST segment depression in our case scenario compared to the classic manifestation of the pericarditis, which can cause ST elevation. So this is not matching as well. All right. And again, we don't have any other best answer here compared to the letter D, onset of new heart failure with a BNP of 758. So eliminating letter B. What about letter C, heart attack with shock from cardiac failure? Why is this incorrect? Now, a heart attack could cause a significant troponin and CKMB elevation, even higher than the levels that you are seeing in the case, right? And troponin levels in the acute MI usually exceeds 1.0 nanograms per ml. And the shock can actually lead to severe hypotension. There's going to be low blood pressure. And this is not mentioned in the question. So we know that heart failure can occur with or after an MI rather, but the lack of the high troponin in the case makes MI less likely to be the primary issue in this question. So take a look into the troponin level of 0.1. This is too low for a major MI. There's no mention of shock symptoms like hypotension or poor perfusion. And so I want you to go back into recognizing the BNP in the case. Anything above 100 should be a red flag. And also rule out those choices that do not match with the findings. Again, pericarditis requires diffuse ST elevation, and the MI should have higher troponin, And the right-sided heart failure that you are seeing in option A should have JVD and peripheral edema, but again, the scenario doesn't mention that one. Okay, and again, you have to focus on the most urgent issue here. The patient has severe respiratory distress. Take a look into the case scenario one more time. The client is intubated immediately. All right, tachycardic. So, yeah, basically, the client is requiring immediate intervention, which aligns with the acute heart failure and the pulmonary edema. Let's take a look at number 16. A client with stage D congestive heart failure has a BNP level exceeding 2,500 picograms per ml. Which medication is the nurse likely to see prescribed by the healthcare provider? Options: A, digoxin IV, B, captopril orally, C, metoprolol, D, Dobutamine IV. What is your answer? The answer is letter D, Dobutamine IV. So I want you to go back into the question stem. The client has stage D CHF. This is the most severe form of CHF, and they're going to have the most severe symptoms as well. And they are at higher risk for acute decompensated heart failure. Now, why is Dobutamine the expected medication to be prescribed here? So let's talk about Dobutamine. This is a synthetic catecholamine. And this is basically going to help improve the cardiac contractility. Okay, that is the main goal. It will help improve the cardiac contractility, and this is going to improve the heart output as well, the cardiac output, I should say. It will increase the cardiac output. It will help effectively pump the circulating blood passing through the heart. Now, this is a medication that is given IV. It acts quickly. It will provide immediate support to the heart's function. And this is also an ideal option for short-term use in critically ill patients with advanced heart failure. Now, one of the key things that you need to remember about Dobutamine is that it is preferred over the other medications like Dopamine. Again, much more preferred than Dopamine because it doesn't increase vascular resistance, okay? Which can actually worsen the heart failure. So, doesn't increase SVR compared to the Dopamine. Now, why is letter A incorrect? Digoxin IVP. Well, we know that this is a cardiac glycoside. This is supposed to be used in heart failure, but it is something that you're going to expect for those clients that has milder form of CHF, okay? So maybe stage C type of CHF, not D. And when you have a patient that has stage D CHF, they need more aggressive interventions in order to support the heart function. And digoxin will not be sufficient in this case, all right? So digoxin here can only help control the rate and also to manage symptom management in less severe cases, all right? So digoxin is intended for less severe cases and also to help with the rate management. Again, we're talking about a very severe form of CHF exceeding 2,500 picograms per ml on the BNP. That's quite high, all right? Now let's take a look into letter B, captopril orally. Why is captopril orally incorrect? This is an ACE inhibitor, right? ACE-I. And this is something that is used in the earlier stages of heart failure, like stage A or stage B. Used for earlier stages, A and B. Now, In these stages, this often involves managing the risk factors like hypertension or diabetes rather than advanced heart failure. We know that the ACE inhibitors are also beneficial for heart failure patients, but again, we need more aggressive intervention for this type of client. Okay. Now, I want to just review you on the captopril orally. What does an ACE inhibitor does? Okay. Remember that an ACE inhibitor is basically going to have that, it will prevent the conversion of the angiotensin 1 to angiotensin 2. Prevents conversion of angiotensin 1 to angiotensin 2. When that happens, then there is going to be a drop or a decrease in the blood pressure. Okay. Because as we remember, angiotensin 2 is a potent vasoconstrictor. Now, if there is decreased angiotensin 2, then of course there is less vasoconstriction. So there's going to be a drop in the blood pressure or normalization of the blood pressure. Another thing is that with the absence of the conversion here, this can also decrease the reabsorption of the sodium and water. And why is that? It's because there is less aldosterone being secreted by the adrenal cortex this time, because we know that angiotensin 2 is supposed to stimulate the adrenal cortex to produce the aldosterone. However, because there is no conversion from angiotensin 1 to angiotensin 2, the aldosterone release will be lesser as well. And so this can lead to lesser reabsorption on the sodium and water in the kidney tubules. So that's going to help decrease the client's blood pressure. But then again, in this case, we are talking about a stage D congestive heart failure. The captopril is not going to be an appropriate treatment this time. It's not going to ease the decreasing cardiac output for this client. They are going to require a much more aggressive form of treatment, which involves the use of Dobutamine IV. Now, why is letter C incorrect? Why metoprolol is not indicated here? We know that metoprolol is a beta blocker as well, right? It is a cardioselective beta blocker. Cardioselective beta blocker. This is going to help reduce the workload of the heart. Okay. But again, this is not going to help immediately the acute situation. And in most cases, the beta blockers are usually not going to be given when there is decompensation, when the client is quite unstable yet. If the client has CHF and their hemodynamics are not stable yet, most of these beta blockers are somewhat held. Okay. So the cardioselective beta blocker is supposed to be resumed once the patient's heart failure manifestations are much lesser. Okay. Again, just to remind you, beta blockers can be given in a stabilized CHF patient, but not during when there is decompensation. All right. So I want to stress that. So let's move on into our next item, number 17. When caring for a critically ill patient with several IV lines and medications, which task can the registered nurse assign to a licensed practical vocational nurse? Options: A, adjust the drip rate of IV drugs that affect blood vessels. B, clear a saline lock using normal saline solution. B, confirm blood products before they're given. D, remove the patient's central venous catheter. The answer here is letter B. That's clear a saline lock using normal saline solution. So when you are the RN in charge of this critically ill patient with so many IV lines and medication, you have to safely delegate this to an LPN or LVN. And you need to make sure that the task that you're assigning to them is based on who has the right training, and also review on the scope of their practice. And so B is the right answer here. they are capable of doing this task, okay? They can handle this technical skill. And flushing it with normal saline is routine for them. It doesn't involve medication adjustments. It doesn't involve monitoring the patient for any reactions, or it doesn't require any clinical decisions. And so they are going to be able to safely do this. And the other options that we are seeing will involve higher risk responsibilities that only RNs can handle. And so letter A is incorrect. Same thing with letter C and letter D. Adjusting the drip rate of IV drugs that affect the blood vessels. Obviously, only an RN can do this. Since we are talking about vasoactive medications, maybe norepinephrine or dopamine, and this can directly affect the blood pressure and circulation. And so this requires an RN to frequently monitor and also adjust the medications based on the real-time changes in the patient's condition. And letter C, confirm blood products before they're given. What about this one? Well, when you are administering a blood product, this is actually going to require 2 RNs or 2 nurses to verify the blood type, to verify the patient ID, and also to verify the unit details to prevent deadly transfusion reactions. Even though LPNs, LVNs can assist with the transfusion in some settings, they cannot perform the critical final check. And so hospital policies and state regulations require an RN to RN verification to ensure safety. Okay. And letter D, we have remove the patient's central venous catheter. Is this something that they can do? All right. Well, they can actually remove a central line, even though this is talking about a central venous catheter. It's actually an invasive procedure that requires assessment. And hang on a second here. Letter D, remove the patient's central venous catheter. So this is basically a central line that will require judgment from an RN as well. And it is a line that is placed in a major vein, like the neck or maybe the chest. And if it is going to be removed in a wrong way, it can cause serious complications, maybe embolism, air embolism. And you have to really instruct the client here on positioning while you are about to remove the central line. And again, this is an invasive procedure that requires careful assessment and monitoring. And this is something that can be done responsibly by an RN. So that's another option that you need to discard. Same thing with letter C, with the confirmation of the blood products before they're given. And so for you to answer this question correctly, I want you to go back into reviewing their scope of practice. I'm talking about the LVNs, LPNs. They can do simple technical tasks like flushing the IVs, insertion of Foley catheters, administering certain medications, and they can handle anything that is predictable. And most of the time, RNs should be doing those tasks that require assessment, that requires decision making, like adjusting IV meds or verifying blood, and also removing any invasive devices. So I want to reiterate those. Let's have number 18. A client with hypertensive crisis is prescribed intravenous Labetalol. What action should the nurse prioritize? A, administer the medication via slow IV push over a period of 5 minutes. B, check the client's Labetalol serum drug concentration. C, educate the client on the symptoms of hypertension. And D, ensure the medication is shielded from light using tinfoil. The answer here is letter A. You have to administer the drug through slow IV push about 5 minutes. And we're talking a client here that has hypertensive crisis, right? You have to administer the medication slowly because it can cause serious complications. It can lead to cardiac dysrhythmias. It can also lead to hypotension. And so the 5-minute IV push can help you control the rate of administration. It will allow the medication to take effect gradually. It will reduce the risk of sudden, severe drop in the blood pressure. And this is something that you should consider in this case. Now, why is letter B incorrect? Check the client's labetalol serum drug concentration. There's no such thing as serum drug concentration of labetalol. This is not necessary for labetalol, okay? It does not require routine monitoring, especially with the drug levels. And the therapeutic levels is based on its dose and the timing, not the blood concentration. So this is an easy to miss option if you're thinking about drugs that typically need serum levels checks, but labetalol is not one of them. Now, why is letter C incorrect? Educate the client on the symptoms of hypertension. Is this the right time to do this? We know that education is also important, but this is not the immediate priority in the case of a hypertensive crisis. Your primary focus is on managing the acute crisis with the appropriate medication and also to ensure safe and a much controlled administration. So the patient is likely already experiencing severe hypertensive episode, and also an immediate action is more critical than educating about symptoms that might not even be noticeable to the patient yet. And so, yeah, disregard that one. Now take a look into letter D. Ensure the medication is shielded from the light using tinfoil. Is this correct? Well, apparently not. Unlike other medications, labetalol is not light sensitive, okay? Not light sensitive. So eliminate this option. All right. So your strategy in answering this question is to focus on the medication's administration guidelines and patient safety. And for any IV medication, especially in a hypertensive crisis, the key is often about controlling how the drug is delivered. So when you're in doubt, slow administration is usually the safer option to avoid severe sudden changes in the patient's condition, especially that we are talking about IV labetalol. 19. While managing a patient with an intra-aortic balloon pump in place, which steps should the nurse incorporate into the care plan? Options: A, monitor the patient's urine production hourly. B, keep the patient lying flat on their back with no head elevation. C, perform gentle assisted movements for all limbs. D, refrain from administering blood thinning drugs. Answer here is letter A. And why is that? Go back into the question. Here we are involved in treating the patient using an intra-aortic balloon pump. Okay. Remember what I said earlier, that this is a device that is going to help the heart pump blood more effectively. Remember about improving cardiac output? That is the main goal. Improve cardiac output. So this is going to help the heart pump more effectively, especially in a client that has cardiogenic shock, wherein the heart cannot pump enough blood to meet the body's needs, or maybe some other serious cardiac issues. So let me explain how this IABP works. Let me erase this one. So the IABP basically is going to work this way. So taking a look into this photo right here, you are seeing that the balloon is inflated, right? We're actually seeing this, we are seeing this balloon being inflated in the descending part of the aorta, right? So this is inflated when the heart is in a relaxed phase during diastole. Okay, I want you to remember this. This is critical in recalling how an IABP works. Again, during the diastolic phase or the relaxation phase, the IABP balloon is inflated. Now, what is the reason why the balloon is inflated? Well, the increased pressure, when the balloon is inflated, the increased pressure will help push more blood into the coronary arteries. So the blood basically is going to be perfused into the coronary arteries, okay? Which basically supply blood, oxygen-rich blood into the myocardium. And so the inflation of the balloon during the relaxation phase will help oxygenate the heart tissues, the coronary arteries, and this simply means that there's going to be more oxygenated blood that will reach into the heart cells. Because with the cardiogenic shock, the heart cells are deprived from the oxygen. And that is the reason why there is such a period of balloon inflation. And the reason for that is to increase oxygenation to the heart cells. That's the reason. Now, there's also that deflation of the balloon. And this is going to happen when the heart is in the systolic phase, when the heart is contracting. And why is this needed? All right. So the deflation can actually reduce the afterload. This will reduce the afterload. Remember what the afterload is? This is basically the amount of resistance that the ventricle is facing. Because the afterload, when there is going to be an increase in the afterload, this can also increase the systemic vascular resistance. And so it is very important that the balloon is going to be deflated during the systole in order to decrease the workload of the heart. Okay, that is the main purpose. To decrease the myocardial workload. Okay. And so, again, this is going to decrease the resistance that the heart has to work again. So it will make it easier for the heart to pump the blood out. And in short, the IABP can help the heart by increasing the blood flow to itself. And it will also reduce the effort it needs to pump blood to the body, which is especially helpful in cardiogenic shock when the heart is struggling to meet the body's needs. So again, remember that the IABP works in two ways. There's going to be deflation and inflation of the balloon. And I want you to remember about what it does during the inflation and what it does when the balloon is inflated. So going back into the question here, why is option A the correct answer? Well, we know that the kidneys are highly sensitive to the changes in the cardiac output. Okay, so back into our theory here, kidneys are supposed to get about 20% of the total cardiac output. Remember about the total cardiac output, it ranges from about 4 to 8 liters per minute. And the kidneys will require about 20% of that. So the urine output alone is a great indicator of how well the blood is being delivered to these organs, especially. Okay. And remember that the kidney is supposed to produce 0.5 mL to 1 ml per kilo per hour. Okay, that is our guideline. So for this patient, our expected urine output should be close to around 30 or 80 mL per hour. Okay, average 40 to 80 mL. So in a patient with an IABP, well, if the device is working properly and the cardiac output is improving, then the urine production will also improve, right? So there should be an increase in the urine production, and this reflects that there is better perfusion. Now, if the kidneys not being perfused, then the urine output drops, right? So this simply means that the intra-aortic balloon pump is not achieving its desired effect, or worse, that the balloon has probably migrated, or probably it's blocking the renal arteries, which could affect the kidney function. So that's why hourly urinary output monitoring is very important here. We are talking about cardiac output. Now, why is letter B an incorrect option? Keep the patient lying flat on their back with no head elevation. So this is basically unnecessary. It could even be harmful. The rationale allows for head elevation, okay, which basically, with this client that has IABP, what do you think about this patient? Maybe they're having some issues with their breathing already. You got to help with their breathing. You're going to have to facilitate their respirations through increasing their head of bed height, right? You need to keep that head elevated because this is quite restrictive, right? This is not going to give any benefit to the patient. It can lead to aspiration risk. It can lead to discomfort and also breathing issues for this client. Now, what about letter C? Perform gentle assisted movements for all limbs. This is also an incorrect option, but why is that? Well, this is partially incorrect because the leg with the IABP, usually the femoral artery, needs to remain as still as possible to prevent the complications like dislodging or kinking the catheter. We know that passive range of motion may be encouraged for other limbs but performing the full range of motion on all limbs is unsafe. And the intra-aortic balloon pump catheter could be dislodged, or it could be damaged with any significant movement of the affected leg. So restricted movement is also important. So this is partially true, partially incorrect. Now, what about letter D? Refrain from administering blood thinning drugs. Is this appropriate? Well, this is totally incorrect because anticoagulation is not really going to work with this type of device. Without anticoagulation, there is going to be a risk of clotting, which could lead to a catheter blockage and other complications. So this is basically not going to help with this client who has an intra-aortic balloon pump. So for you to answer this question, I want you to focus on the most critical assessments for the device. Again, recall the purpose of the IABP, and this is to improve the cardiac output and also to improve organ perfusion. And that is why urine output monitoring hourly is our best choice. And I want you to eliminate those options like keeping the patient flat on bed, which is uncomfortable and unnecessary, and full ROM, which is option C. This could lead to displacement of the catheter, which you want to avoid. And also refraining from administering blood thinning agents would cause the patient at risk for blood clot formation, which is counterproductive to the treatment goal. Alrighty, let's have number 20. A patient with congestive heart failure is prescribed Milrinone lactate. What is the nurse's priority action? Option A, measure the patient's apical pulse. B, review the patient's BNP levels. C, observe the patient's telemetry readings. D, evaluate the patient's respiratory condition. The answer here is letter C, observe the patient's telemetry readings. Now, let's review on the Milrinone lactate. So what is this medication? This is a phosphodiesterase inhibitor. Okay, so this is used in treating heart failure, and the primary side effect for the medication is severe arrhythmias. So you have to be careful when administering this drug. And so your safeguard here would be to monitor the client's rhythm, which is in letter C. because this will provide you better picture of the continuous activity of the heart to detect any arrhythmias early on, and also will help you manage those arrhythmias early and also to treat them. Okay. Now, what about letter A? Measure the patient's apical pulse. We know that this is also important for many cardiac medications, but telemetry is much more comprehensive, and it is a continuous monitoring tool, especially when a patient is on a medication, Milrinone. And the apical pulse, take note, apical pulse, you have to physically assess the client with the use of that stethoscope. And so this is an action that would require you to have a physical contact with a client, right? Unlike telemetry readings, this is very observable, and this is much more real time. There is continuous detection of any life-threatening arrhythmias. Now, what about letter B? Review the patient's BNP levels. This is another incorrect option, but why is that? This is a lab work that is going to help detect heart failure and also to assess the severity of the CHF, but it is not an immediate concern once the patient has already been diagnosed with the congestive heart failure. And this is only specific treatment to Milrinone. Now, what about letter D? Evaluate the patient's respiratory function. Is this going to be a correct option? Well, we know that respiratory assessment is also critical for patients with a CHF, especially if there is fluid buildup in the lungs and pulmonary edema. But cardiac monitoring takes much more priority when the patient is receiving the medication that can cause the severe arrhythmias. So you got to make sure that you are monitoring this client continuously to detect these irregular heart rhythms. All right, this can be life-threatening. Let's have number 21. What observation most clearly shows that fluid replacement has worked for a 90-kilogram patient experiencing hypovolemic shock? Options: A, mean arterial pressure registers at 72. B, central venous pressure falls within the normal range. C, urine output reaches 65 mL in the last hour. D, hemoglobin levels are in the expected normal range. The answer here is letter C. Why is that correct? Well, we know that the body's kidneys are very sensitive to the blood flow and the perfusion. And in a client that has hypovolemic shock, the body circulation is compromised because of the significant loss of fluid. Could be from dehydration, could be from bleeding. And when the IV fluids or blood, let's say, are being administered, then one of the key indicators that the perfusion has been restored is the kidney's ability to produce urine. Now, for this client that weighs 90 kilograms, the normal output is supposed to be measured. And again, I want you to do this calculation when you're going to be encountering this type of question. This is much more specific rather than relying on the minimum 30 mL per hour urine output. I would rather use this rather than the 30 mL per hour common guideline, because this is much more specific. And so it's for this client that is 90 kilograms, then you're going to multiply that by 0.5 or 1 milligrams per kilo per hour. So basically, the client will have urinary output close to about 45 to 90 mL per hour. And for this client that has a urine output, let's say we're going for this letter C, right? 65 mL. So the client's output is within the normal range, and it's very healthy. It signals that the kidneys are now receiving enough blood flow to function properly. So this is reflecting that the fluid resuscitation is working, and it is also improving organ perfusion. Now, why is letter A incorrect? Mean arterial pressure registers at 72 mmHg. We know that is quite in the normal range, right? This is basically a measurement that is used to assess organ perfusion. Okay, so it reflects the pressure that drives the blood through the organs, but it's not as reliable or not as specific compared to the urine output when it comes to hypovolemic shock recovery. We are talking about the effectiveness of the fluid replacement. Okay, so basically we're just looking at the pressure. We are not looking at the end effect. No assessment of end effect. What we want is to look if there is really an improvement. We want end organ perfusion. It's just giving us a value, but no, it doesn't give us a good information about if there is an improvement to the tissue perfusion, which is basically reflected by a good urine output. Now, what about letter B? Central venous pressure falls within the normal range, CVP. We know that the central venous pressure is going to assess the pressure in the right atrium of the heart. It will reflect the amount of blood returning to the heart, which is the preload, right? And with the normal CVP, typically around 2 to 8 mmHg, 2 really is on the low end, right? It can indicate that the venous system has been replenished, right? Or there is now, let's say, restoration of the fluid volume circulating. But it does not directly tell you that the organs are being perfused. So basically, it's just giving you a value of the pressure, but there is no assessment of the end effect. All right. And also the CVP can also be influenced by so many factors, maybe the heart function and also the intrathoracic pressure. So there are so many things that are involved. So it's not as reliable compared to the urine output. It does not assess end organ perfusion. Okay. Let me write this down to emphasize. So, important assessment is end organ perfusion. This is what we are looking for in this hypovolemic shock. It simply means that there is now a evidence that the IV fluid replacement has really done its job. Now, what about letter D? Why is this incorrect? Hemoglobin levels are in the expected normal range. Do you think that fluids can do that? Well, no. The hemoglobin measures the oxygen carrying capacity of the blood. We know that it's true that in cases of hypovolemic shock due to hemorrhage, hemoglobin levels might drop. And the fluids can actually cause a dilution of the blood product. And so hemoglobin alone does not give you a direct information about how well the body is being perfused. And it's possible for a patient to have a normal hemoglobin level and still not have a good tissue perfusion. Therefore, the hemoglobin levels are not a strong indicator of fluid resuscitation success. All right, so in situations like this, like hypovolemic shock, the goal of fluid replacement is to restore perfusion to the vital organs like the kidneys. And so urinary output assessment is going to give us a more direct and reliable indicator of successful fluid resuscitation. And you got to eliminate those other options, those measurements, MAP, CVP. These are just giving you a good picture about the pressure, but this is not going to give you an evidence that there is positive organ perfusion. All right, I hope that you are learning from this one. 22. A nurse is assessing a patient with pericardial effusion at 0900 hours. The apical pulse is 76 beats per minute and blood pressure is on 136/92. 11 a.m., the patient develops neck vein distension. The apical pulse drops to 70 BPM and blood pressure falls to 105/92. What should the nurse prioritize doing first? Options. A. Remain with the patient, stay calm, and call the nurse's station. B. Immediately contact the healthcare provider. C. Position the patient on their left side. D. Administer intravenous morphine slowly. The answer is letter A. And why is that? Well, the patient is showing signs of worsening hemodynamic instability. So take a look into the changes in the heart rate and the blood pressure. Okay. There is a drop, considerable drop in the blood pressure from 136/92 to 105/92, right? And take a look into the assessment. There is also development of neck vein distension. So these are signs that can point that the client is developing cardiac tamponade. And the client already has a diagnosis, an established diagnosis of pericardial effusion. This is going to allow more collection of fluid into that pericardial sac. It can drown the heart. It will not be able to contract properly because there is accumulation of fluid in the sac. So it's kind of like constricting. It's not going to be able to, it's not going to allow the heart muscle to contract and push the blood out from the chambers. And so what you should do here is to remain with the patient and stay calm and call the nurse's station. This is very important for you to monitor the client's condition in real time. It can also provide emotional support to the client. It will reduce anxiety, which could actually help decrease the possible complications, because the more that they get anxious, the more that there's going to be changes in those oxygen demands. Now, when you're calling the nurse's station, this is going to ensure that you will get the necessary support and also the necessary resources. And making sure that you are calm and collected will provide you an initial assessment while waiting for guidance from the healthcare provider. Now, why letter B is incorrect? Immediately contact the healthcare provider. We know that contacting them is important, but this is not the first action. You need to stay with the client first, observe their status, and provide initial support before making that call. And you need to monitor the client's condition while calling the nurse's station or the healthcare provider. And immediate contact with the healthcare provider should follow after you had ensured the client's safety. Now, why is letter C incorrect here? Position the client on their left side. Well, left side positioning is going to be beneficial in patients that may be getting enema. There is no evidence that you're going to, no evidence at all that there's going to be benefit about positioning the client on their left side with a pericardial effusion, right? And the immediate need here is to stabilize the client's condition, and the positioning alone, putting them on their left side, will not address the possible cardiac tamponade. Now, letter D, administer intravenous morphine slowly. Do you think that this is appropriate? Well, this is indicated for pain management, for clients who may have myocardial infarctions, or for those clients that may have trouble breathing. And in this case, the priority is stabilizing the patient's hemodynamic status. So you got to stay with the client, ensure that they are monitored, and you are calling for appropriate intervention. And if you're administering morphine without understanding first the underlying cause of the patient's worsening situation, could be premature in that sense. All right. So I want you to focus on the sequence of the priorities in an emergency situation. So in a case of a worsening clinical scenario, your immediate responsibility is to stay with the client, monitor them closely, keep calm and collected to ensure that appropriate support is needed. All right. 23. What critical step will the nurse add to the care plan for a patient experiencing cardiogenic shock? Options: A, examine the skin for redness or irritation. B, keep the patient lying flat at all times. C, measure body temperature every couple of hours. D, listen to lung sounds on a regular basis. Answer here is letter D. And why is that? Again, cardiogenic shock occurs when the heart is no longer able to pump the blood effectively. And most often, the cardiogenic shock is caused by left ventricular dysfunction, usually in the left-sided heart failure or after a major heart attack. And so the result here is that it can cause backup of the blood into the lungs. It will increase the pulmonary pressure, right? It will cause pulmonary edema, accumulation of the fluid inside the lungs. And one of the classic symptoms of pulmonary edema is dyspnea. There's going to be crackles. There's going to be wet lung sounds, which you can hear during the lung assessment. And even without the use of a stethoscope, some of these patients with the worsening pulmonary edema can actually sound very crackly. There's going to be audible crackling sound. And this is going to be very important for you to assess, right? You need to listen to the lung sounds every 1 to 2 hours. And this can help you detect if there is worsening of their congestion early on. And if the crackles are heard, it basically signals that the fluid is building up increasingly, and it is requiring for more immediate interventions, possibly needing the administration of loop diuretics, Lasix, or possibly the administration of inotropic agents in order to strengthen the myocardial contraction. And this is also important for us to deliver timely intervention. All right. Now, what about letter A? Why is this incorrect? Examine the skin for redness and irritation. We know that this is also important, right? To detect for the perfusion through skin observation. We're going to have to look for the redness, maybe irritation or flushing. But these are not typical manifestations of cardiogenic shock. So, not typical manifestations of cardiogenic shock. So eliminate this one. Now, what about letter B? Keep the patient flat at all times. Do you think this is appropriate when your client is in cardiogenic shock? Your client probably has an edema now in the lungs. This is counterproductive. This is going to worsen their shortness of breath. This will allow pooling of the secretions inside the lungs. It's going to get this client drowning. And the head of bed should be elevated this time. You got to keep this patient on a sitting position to promote easier breathing. Now, what about monitoring the temperature every couple of hours? Is this appropriate? We know that temperature monitoring is also essential in some cases. But fever is not a typical sign of cardiogenic shock unless there is an underlying infection like endocarditis or the infection of the heart valves. And again, this is not the focus of care for this specific situation. So I want you to focus on the clinical signs directly related to the shock type. And in this case, we are talking about cardiogenic shock. We are concerned about contractility, okay? Contractility of the heart muscle, and also the backflow of the blood from the left side of the heart into the pulmonary circulation. From left ventricle to the lungs. Okay? In short, that is pulmonary edema. And that is why The best action here is to listen to the lung sounds on the regular basis. Okay, so this can happen so quickly. And I want you to eliminate those options that don't really impact the patient's condition, like temperature assessment, skin examination. These can be applicable or much more relevant to other situations. Here, we want immediate assessment that can pinpoint the real problem. Okay, and here you should eliminate this one right away. Lying flat at all times will not benefit the client who is in cardiogenic shock. 24. The nurse is reviewing the doctor's order for a patient diagnosed with CHF. The prescription is for 2.5 milligrams of lanoxin to be administered orally or daily. What is the nurse's next step? Options: A, consult with the healthcare provider about the order. B, check the client's apical pulse rate before administering the medication. C, verify the client's potassium levels before administering the medication. D, confirm if a digoxin blood level has been measured. All right, let's take a look into the question stem. The client has a prescription for lanoxin 2.5 milligrams to be administered daily. The correct answer here is to consult with a healthcare provider, because the dose that is given is probably ordered in error. So you need to question the provider's order. The dose is significantly higher than the usual daily dose. Okay, the typical daily dose is around 0.125 to 0.25. So I want you to remember the regular daily dosing. All right, so 2.5, that's too high. This is dangerous for this client. This is possibly transcription error, and you need to clarify the order to ensure the patient's safety. And first things first, you need to check the correctness of the order. That should be included as part of your medication rights, right? You need to identify the right dose of the medication. All right. Now, why is letter B incorrect? Check the client's apical pulse rate before administering the medication. Well, this is a good action after everything has already been clarified, right? You have to count the apical pulse for a full 60 seconds or a full minute if the heart rate is irregular, right? This is a good practice. Only if you're done verifying the erroneous order. Letter C, verify the client's potassium levels before administering the medication. Also a good practice, but this is something that you can do once the order has been verified as well. And letter D, confirm if the digoxin blood level has been measured. Yes, of course, you can also do this, but it is a second step, not the primary step here. Obviously, the order is too high. This can lead to dig toxicity. Okay, you need to identify the most urgent issue in this question. It is the incorrect medication dosage. Wrong dose issue. 25. A patient admitted with severe hypotension and dehydration has a prescription for norepinephrine. Which finding prompts the nurse to discuss with a healthcare provider before beginning the medication? Options: A, the patient's heart shows a rapid sinus rhythm at 120 beats per minute. B, the patient has not produced any urine since arrival. C, the central venous pressure reads 2 mmHg. D, the patient is on a low dose of dopamine. All right, so your client here comes in with hypotension that is severe, dehydration as well, and the client has norepinephrine prescription. All right, this is going to be fun. There is now a drug involved. So, which of these options should be the answer? Well, the correct answer here is letter C. The central venous pressure reads 2 mmHg. It's still within that range. Very low though, okay? And I want you to remember that norepinephrine, this is a vasopressor. And this will constrict the blood vessels to raise the blood pressure. And this is a common drug that is used in sepsis, which is a distributive type of shock. And the problem here, though, is that the client has dehydration. There is a lack of fluid volume. That is the main issue here. All right. So the patient's system is underfilled. The client is dry. And it's shown in the CVP reading as well that is low, 2 mmHg. It's in the low end. Normally it should be around 2 to 8 mmHg. Now, if the CVP is low, it indicates that there is volume depletion. The client's body is not getting enough fluids. And so, if you are going to start the norepinephrine without stabilizing first the client's fluid volume, this can worsen the organ perfusion. This can cause excessive vasoconstriction, which will worsen the perfusion to the vital organs. So it will basically tank the circulatory volume. All right. So what you should do in this case is to replace the client with fluids first, and then followed by the norepinephrine. Okay. Always think about that, especially that we have a case about a dehydration. So as a nurse here, you need to make sure that the patient has adequate fluid volume before you cause vasoconstriction. Because if you're just causing vasoconstriction without adequate fluid volume, you're just compromising the depleted blood supply to the vital organs. You're actually worsening the decreased perfusion if you are not doing this sequence. All right. So again, you have to replace fluids first. Now, what about letter A? Why is this incorrect? The patient's heart shows a rapid sinus rhythm at 120 beats per minute. Tachycardia is a common manifestation in hypovolemia because the body is trying to compensate for the low blood volume. So it's trying to increase the heart rate to maintain cardiac output. And it is a typical response, and it's not a contraindication to the norepinephrine. And in fact, norepinephrine could even raise the heart rate more due to its beta effects. And let's take a look at letter B. Why is letter B also an incorrect? The patient has not produced any urine since arrival. Basically, this is, I would probably say, oliguria or anuria, which is a concern of hypovolemic shock because it detects or it signals that there is poor kidney perfusion. However, this is expected in the early stages of hypovolemic shock because the body is trying to shunt the blood into the other organs, and it doesn't specifically prevent the use of norepinephrine. And we know that norepinephrine, along with the fluids, can help improve perfusion to the kidneys, leading to the urine production. Now, what about letter D? The patient is on a low dose of dopamine. Why is this incorrect? Well, the low dose dopamine, which is typically, like I've said earlier, 2 to 5 micrograms per kilo per minute. Okay, so this is going to be used to maintain renal perfusion in shock, especially in hypovolemic shock. But it also has a mild vasopressor effect, but primarily improves the renal blood flow. So this is a medication that can be used along with the norepinephrine and shock scenarios, especially when there is a concern about kidney perfusion. Now, what I want you to do here is to focus on the patient's volume status. Your patient is dehydrated. There is severe hypotension. And the reflection here is the client's venous pressure of 2 mmHg. Okay, so when you are going to treat this patient with norepinephrine, you make sure that the client has adequate circulatory volume before you start this drug. Okay, again, the CVP is a reflection that the client is depleted of circulation volume. All right, let's have number 26. For a client experiencing an anaphylactic reaction, which nursing action should be given the highest priority? Option A, administer IV epinephrine. B, prepare for urgent endotracheal intubation. C, offer calm reassurance during care. D, ensure the airway is clear and unobstructed. The answer here is letter D. And why is that? This is the highest priority intervention when you're managing an anaphylactic reaction. It's because the airway is the first concern in anaphylaxis. Remember about the narrowing of those airways, the bronchus, the bronchioles, and this is because there is that risk of laryngeal edema. There's also angioedema, which can cause the swelling of the tongue, which is a muscle, right? It can obstruct the airway. And there's also bronchospasm, which can cause a rapid obstruction of the airway. So let me list them down. Laryngeal edema, angioedema. These are not a joke, all right? Have you experienced this? Then if not, you can sit this out. Just kidding. And so, in a client that has an anaphylactic reaction, these are the primary concerns: laryngeal edema, angioedema, and bronchospasm. If the airway is compromised, no other interventions will be effective. And this is why you ensure an open airway, and this should be priority. Now, why is letter A not the best answer here? I did not say that this is incorrect, but not the best answer. The epinephrine IV is a very critical medication in treating the anaphylaxis because it will work as a vasoconstrictor. It can also work as a bronchodilator to counteract the effects of the histamine release. However, this is not the immediate priority. Even though the epinephrine is critical, you have to secure the airway first. If the airway is obstructed, the epinephrine won't be able to reach its target because the patient will not be able to breathe properly. Now, what about letter B? Prepare for urgent endotracheal intubation. We know that this is necessary in some cases of severe airway obstruction, but this step is usually performed after first securing the airway using less invasive measures like positioning or inserting an airway adjunct. And so intubation is not the first action unless less invasive interventions are ineffective. All right. So there should be other steps involved here before you are going to prepare for the endotracheal intubation. All right. I did not say that you're not going to be expecting this to happen, but not the best option this time yet. Now, what about letter C? Offer calm reassurance during care. We know that this is important, but it should not be priority in a life-threatening situation like anaphylaxis. The patient's physical needs must be met first. Again, once the airway is secure and the patient's breathing is stable, then you can focus on offering comfort and reassurance. So for you to answer this question, I want you to approach it with the ABCs. Okay? Always prioritize interventions that can address the most intermediate or immediate life-threatening issues first, and make sure that you're securing the airway in an anaphylactic reactions. Okay? So, in such cases, identify what would cause the most harm if left unaddressed. It should help guide you toward the correct answer, which is letter D. What about number 27 here? While monitoring a patient on a nitroprazide drip for cardiogenic shock, which observation suggests to the nurse that the medication is working? Options: A, skin appears warm and pink. B, troponin levels show a reduction. And letter C, blood pressure measures 92 or 40 mmHg. And D, no new murmurs are heard in the heart. The answer here is letter A. And why is that? Well, because when a patient is in a cardiogenic shock, the heart is struggling to pump the blood effectively, which leads to decreased cardiac output, decreased blood pressure, decreased tissue perfusion. And so typically the skin will appear cold, pale, and clammy because the blood is being shunted away from the periphery to the vital organs. And the medication nitroprazide, which is a potent vasodilator, this is going to help relax the blood vessels. It will reduce the afterload, which is basically the resistance the heart has to pump against. And this is going to help improve the cardiac output and subsequently improve the tissue perfusion. And so this medication can help oxygen-rich blood to go into the peripheral tissues more effectively. And if the skin appears warm and pink, it simply means that the capillaries are open and they are oxygenated and is now reaching the tissues. And it shows that the nitroprazide is doing its job. And so this is the time when the end organ perfusion comes back to life again. All right. And organ perfusion. So don't forget that. So this is the correct answer. Why is letter B incorrect? Troponin levels show a reduction. We know that troponin is a marker that is going to help you detect for any heart muscle damage after an MI. We know that elevated troponin levels indicate heart damage, and they do not increase or decrease, rather. They do not decrease quickly. And it is a sign of injury, not a real-time perfusion. And so the reduction in troponin levels is not a direct indicator of the nitroprazide working because the drug does not affect troponin levels. And the goal of the nitroprazide is to improve tissue perfusion, not reduce the cardiac injury markers. And so with letter C, let's see, blood pressure measures 92/40. So this is low and might seem concerning at first. However, the nitroprazide works by lowering the blood pressure to reduce afterload. Okay, and the low blood pressure is often expected when using the medication. And the low blood pressure alone is not a definitive sign of effectiveness. And the key indicator for the effectiveness is whether there is improved perfusion, which is why the skin that is appearing pink and warm are key. And while we know that low blood pressure might be a side effect, it does not automatically signal that the drug is working. All right. Now let's take a look into letter D. No new murmurs are heard in the heart. Okay. So what are these murmurs? These are typically caused by a valvular or structural heart issues, but it's not directly related to the effects of the shock or the action of the nitroprazide. Now, the absence of new murmurs is not related to the shock reversal or the nitroprazide's mechanism of action. And the presence or the absence of the murmurs does not indicate whether the cardiac output or tissue perfusion is improving. And so I want you to focus on the clinical signs of perfusion first. And again, this is the most important thing for you to do. You have to look for that effectiveness of the medication, whether the perfusion is improving, okay? Not just about blood pressure numbers. So if there is going to be pinkness or there is a warm sensation of the skin, Okay, this basically is an indicator that there is improvement of the tissue oxygenation and there is improvement of the blood flow. And so I want you to eliminate those options such as the troponin levels that is reducing. This is not a sign of shock reversal, and the blood pressure in option C doesn't necessarily mean the drug is working. And the heart murmurs in letter D are linked to structural problems, not the success of the vasodilator in shock management. Okay, let's have number 28. A client with heart failure is receiving an intravenous dose of furosemide. How quickly should the nurse expect to see the therapeutic effects of the medication after administration? Options: A, within 30 to 60 minutes, B, immediately in 5 to 10 minutes, C, within 2 to 4 hours, D, after 6 to 8 hours. The answer is letter B, and why is that? Well, when you are administering Lasix or furosemide for heart failure, you have to understand how quickly this medication works to alleviate the manifestations of fluid retention and possibly pulmonary edema. And recall that furosemide is a loop diuretic. It's going to cause the kidneys to excrete those excess sodium, chloride, and water. So this will also reduce the fluid buildup in the body. And during an emergency, a client is going to benefit the use of an IV route of the Lasix. And so this is basically important, especially for those patients with acute decompensated heart failure, because it will provide a rapid therapeutic effect. And so when you are giving the IV furosemide here, the onset of action basically will be around 5 to 10 minutes. Okay, this is the expected onset, and the peak will be around 30 minutes. So remember this, we are talking about IV furosemide. It acts very quickly. It can actually cause symptom relief immediately when the client has pulmonary edema, and it can last to about 4 to 6 hours. All right. Now, why is letter A incorrect? Within 30 to 60 minutes. This is not the correct onset. This is pertaining to the peak of the furosemide. So this is incorrect. Now, what about C? Within 2 to 4 hours. Onset? Well, this is going to be the effect of the medication when you are giving the oral furosemide. So this is going to be the peak for oral furosemide. All right. Now, what about 6 to 8 hours? Why is this incorrect? Why is this incorrect? This is too long. When you are administering an IV Lasix, it is going to work so quickly. And you will see the effects right away within a few minutes to about an hour. So you got to get ready with the diuresis here. You will be monitoring the urinary output right away. You will see clear urine flowing through the urinary catheter bag. It's kind of awesome to watch this one. So for this question, I want you to pay close attention to the route of administration, and especially for the IV medication. You have to be mindful about the onset of actions, and especially with IV furosemide, the onset is faster than the oral or other routes. Okay. 29. Which assessment finding is most crucial for the nurse to evaluate when determining the effectiveness of treatment in a patient experiencing anaphylactic shock? Options: A, blood pressure, B, mental status, C, oxygen saturation, D, heart rate. The answer is letter C. All right, let's go back into the question here. Client is experiencing an anaphylactic shock, and it said which assessment finding is most crucial for the nurse to evaluate when determining the effectiveness of the treatment. All right. Why is letter C the correct answer here? Again, remember about the anaphylactic shock? This is that severe allergic reaction that causes the airway to swell up. It can cause bronchospasm. It can cause angioedema, laryngeal edema. It's not your typical shortness of breath. It's way worse than that. And the swelling can impair the patient's ability to oxygenate properly, which is why the oxygen saturation is the most critical indicator to assess during the treatment. Now, this is also going to reflect how well the oxygen is being delivered to the tissues, and adequate oxygenation is very critical for the client to survive, especially in this type of shock. Now, if the airway is not managed effectively with the epinephrine or the antihistamines, or let's say corticosteroids, the client's oxygen levels will remain low despite the other interventions. Now, even if other signs like blood pressure or heart rate is going to improve, the priority is ensuring the airway is clear and oxygen is being delivered properly to prevent the respiratory arrest. And that is why O2 saturation, which is measured by the pulse oximetry, is the best indicator of how well the treatment in anaphylactic shock is working. All right, I hope that clarifies the cloudiness. Now, why is letter A not the best answer? All right, we know that the blood pressure monitoring, or the blood pressure is also an important to monitor during an anaphylactic shock. But the anaphylaxis primarily affects the airway and the breathing due to the airway swelling, right? The blood pressure can be low in shock due to the vasodilation, but oxygenation is a more immediate concern. And the treatment with the use of the epinephrine can help elevate the blood pressure, but the priority is airway and breathing, which is reflected in oxygen saturation. All right. Now, what about letter B, mental status? This is also a critical sign to evaluate in any patient, especially in shock. As we know that there is decreased oxygenation can also lead to confusion. It can lead to altered consciousness, but changes in the mental status are often secondary to more immediate issues like airway obstruction or hypoxia. Never neglect that ABC format. We know that an improvement in mental status might be a sign that the patient is getting enough oxygen, but the most direct and immediate indicator of treatment effectiveness is the oxygen saturation. If the oxygen improves, the patient's mental status will likely improve as well. The same thing with the blood pressure. Okay. Now, what about the heart rate here? Why is this incorrect? We know that the heart rate can be elevated during the shock because the body is trying to compensate for the poor perfusion. And the heart rate is a good indicator of the body's compensatory response, but it is not the most critical indicator in this case. Because if the anaphylaxis is occurring, the oxygenation is compromised first, not the cardiac output. So I want you to focus on the primary issue in the scenario. The question stem describes anaphylactic shock, which is primarily caused by airway obstruction and difficulty of breathing due to severe allergic reaction. So this should lead you to prioritizing letter C, okay? So prioritize airway and breathing over other symptoms like blood pressure or heart rate, all right? 30, a patient with a history of left-sided heart failure is showing signs of worsening condition. Which of the following clinical findings suggests that the patient may be developing pulmonary edema? Select all that apply. Options: A, swelling in the lower extremities, B, loss of appetite, C, rapid heart rate, D, audible coarse crackles in the lungs, E, elevated jugular venous pressure. The answers are options C and D. So in this question, it's critical for you to connect the patient's history of the left-sided heart failure and with the clinical manifestations of the pulmonary edema. All right, remember about that backflow of the circulation from the left ventricle into the lungs, and that is a common complication. And this heart failure, the left-sided heart failure, primarily affects the heart's ability to pump blood effectively. Instead of moving the blood forward, it's now allowing the blood to go backward and into the lungs. And this backup of fluid is what's going to cause pulmonary edema, and that is why there's going to be accumulation of fluid in the alveoli and the respiratory system. And so the client will end up with difficulty of breathing. There's going to be abnormal lung sounds. And that's why we have letter C, and there's also going to be letter D. All right. So why is rapid heart rate one of the correct options here? Well, because during a pulmonary edema, there is poor oxygenation. This is a compensatory response to the pulmonary edema, because also the heart struggles to pump blood effectively due to the fluid buildup. There is just so much fluid to pump, and the body is trying to compensate by increasing the heart rate to maintain the adequate blood flow. And this is a very common symptom that suggests pulmonary edema, because the body is trying to overcome the respiratory distress and overcoming and wanting to improve the circulation. And so heart rate that is elevated is a strong sign of pulmonary edema and left-sided heart failure that is worsening. Now, what about letter D? Audible coarse crackles in the lungs. So we're talking about coarse crackles. This is what I said earlier. Even without the use of a stethoscope, you can hear the client's raspy breathing. And this is caused by the accumulation of the fluid in the alveoli and the small airways. And this is a hallmark sign of pulmonary edema. So again, this is abnormal breath sounds, which can be heard even during when you're just seeing the patient, even without the use of the stethoscope. I did not say that you're not going to use a stethoscope to auscultate, but you can also hear this coarse crackles. Now, let's take a look into the other options, such as letter A, swelling in the lower extremities. Why is this incorrect? Well, this is going to be associated with the right-sided heart failure, okay? The case scenario is talking about left-sided heart failure. And when you have a client that has right-sided heart failure, the issue is in the venous system. If we have the left or the right ventricular failure here, the right side, this can cause a backup of the fluid into the venous system, right? And so this is easy to spot for the right-sided heart failure. There's going to be peripheral edema. You will see this in the ankles. You will see this in the client's legs. There's going to be loss of appetite because of the increasing pressure in the abdominal area. There is enlargement of the cavity because of the ascites. There's also congestion in the liver. And with this backflow into the venous circulation, this can cause the JVD to appear. Positive JVD, jugular venous distension. So even if the patient is sitting upright in their hospital bed, you can still see the jugular vein congested, or it's very obvious to see. And so you are eliminating options A, option B, and option E. These are signs of right-sided heart failure. What we are looking at are those signs of left-sided heart failure. So most of the manifestations that you will be seeing in the left-sided heart failure are pulmonary manifestations. So don't forget that. 31. Which assessment finding suggests that a patient with cardiogenic shock may be progressing to multiple organ dysfunction syndrome, or MODS. Options: A, diminished peripheral pulses and cold extremities. B, increased serum creatinine concentration. C, reports of episodic chest discomfort. D, presence of crackles in both lungs. The answer here is letter B. Why is this correct? Again, going back to the cardiogenic shock. This is happening when the heart is unable to pump blood effectively out from the left ventricle to the system. This can lead to poor oxygenation and perfusion to the organs. Now, since we're talking about MODS, this is a progression where the multiple organs begin to fail due to the lack of adequate blood flow and oxygen. And so that's why it points to the elevation of the creatinine level. So this is a direct indicator of kidney impairment. We know that the kidneys are supposed to receive 20% of the total cardiac output. And so if there is decreased blood flow to the kidneys, this is going to show up. There's going to be elevation of the creatinine. The kidneys are no longer able to excrete the creatinine out of the system. All right. And so the kidneys here are pretty much struggling to filter the waste due to the inadequate blood flow, which can signal the progression to the MODS. All right. Now, why is letter A incorrect? Diminished peripheral pulses and cold extremities. Well, diminished peripheral pulses and cold extremities are common signs of cardiogenic shock, especially in the early stages. Okay? All right? Because these are a result of poor peripheral perfusion due to the heart's inability to pump the blood effectively. However, these manifestations do not directly indicate the progression of MODS. All right? Now, we know that it is important to monitor these, though, but they are expected findings in cardiogenic shock and do not provide conclusive evidence of multi-organ dysfunction. And again, it's non-specific manifestations and doesn't really reflect the failure of other organs like the kidneys, liver, or the lungs. Now, what about letter C, reports of episodic chest discomfort? Well, this is something that might be associated with a cardiogenic shock, especially if there is an underlying myocardial infarction or ischemia that is contributing to the heart failure. However, saying episodic chest discomfort is more an indication of acute myocardial ischemia or maybe an ongoing cardiac event rather than an onset of MODS. All right, so eliminate this one. Now, what about letter D, presence of crackles in both lungs? Now, the crackles in both lungs are a sign of pulmonary congestion or edema, and this is a common manifestation in cardiogenic shock. And this is happening because of the heart not pumping effectively, which can lead to the backflow of the blood into the lungs. And we know that the crackles in the lung assessment is very critical in monitoring the client's respiratory status, but they do not directly indicate that the other organs are failing. And so, again, this is not going to really reflect the MODS. So for you to answer this question correctly, I want you to identify the most specific sign of organ dysfunction. And again, that is the elevation of the creatinine level. Okay, this is the most specific finding related to the progression to MODS. The other options reflect expected symptoms of the cardiogenic shock, but none of them point to renal failure, which is a critical marker of MODS. We are talking about multiple organ dysfunction syndrome. So if there is now an elevation of the creatinine, then that is significantly reflecting that AKI is developing. All right. Now let's have number 32. A 58-year-old female, or male rather, with a history of coronary artery disease has been admitted after suffering a severe myocardial infarction. He is currently in the ICU, where his vital signs show low blood pressure, weak peripheral pulses, and cool extremities. The healthcare team is concerned about the development of cardiogenic shock. Based on the clinical presentation, which of the following characteristics is most consistent with cardiogenic shock? Options: A, decreased myocardial contractility; B, increased cardiac output; C, hypovolemic shock; D, ischemia. So I hope that you can point the correct answer right now, since we've already talked so much about the cardiogenic shock in previous test items. So your answer here should be letter A, decreased myocardial contractility. So you have to focus on the specific pathophysiology of a cardiogenic shock, because it relates to the myocardial infarction that happened to this client, right? And this is something that can occur most commonly because of the decreased myocardial contractility. This happens as a direct result of the damage from the severe myocardial infarction. If the heart muscle is infarcted, it's already dead. It's not going to be able to contract. It's not going to be able to squeeze the blood out from the ventricles. It's non-workable muscle anymore. It's dead, right? So the issue here is about the pumping. There's a significant drop in the contractility, and that is why cardiogenic shock is happening. All right. And so when this happens, you are going to assess for the development, the manifestations of the cardiogenic shock. Okay, there's going to be decreased cardiac output, as evidenced by low blood pressure. Okay, where's me? So decreased CO, there's going to be decreased in the blood pressure, there's going to be decreased in the peripheral pulses, and there's also cool extremities. And what else? If there's decreased cardiac output, there is decreased urine output, and also the possibility of AKI, the acute kidney injury. There's going to be elevation of creatinine levels. Okay, there's more manifestations and labs, but I'm just going to limit those for this situation. Now, what about letter B? Why is this incorrect? Increased cardiac output. Yeah, we already identified this one, right? There's no increased cardiac output in cardiogenic shock. The exact opposite is happening instead. Hypovolemic shock is also incorrect. Why is this incorrect? Because hypovolemic shock happens when there is a reduction of the blood volume or fluid volume. Could be from severe bleeding or fluid loss from dehydration. And this is totally a different type of shock, okay? The problem with hypovolemic shock is that there is the lack of fluid volume. In cardiogenic shock, there is no issue in the fluid volume, all right? Letter D, ischemia. Why is this incorrect? We know that ischemia is a contributory factor in myocardial infarction, since it results from a lack of blood supply to the heart muscle and then progresses into the infarction, but it is not the defining characteristic of the cardiogenic shock. And we know that ischemia is the lack of oxygen supply to the tissues, although it's involved in the pathogenesis of the infarction that led to the cardiogenic shock. The primary feature of the shock is the impaired ability of the heart to contract, not just about the ischemic damage. And that is why we are eliminating this one. So for you to answer this question correctly, I want you to focus on the core pathophysiological mechanism of the condition. And again, when it comes to the cardiogenic shock, you really need to go back into the issue of decreased contractility. All right. The pumping function of the heart is decreased. 33. A patient diagnosed with septic shock has a blood pressure of 72/45, a heart rate of 140 beats per minute, a respiratory rate of 35 breaths per minute, a temperature of 105 degrees Fahrenheit, and a glucose level of 260 milligrams per deciliter. Which provider order should the nurse carry out first? Options. A. Administer 650 milligrams of acetaminophen Tylenol rectally. B. Begin norepinephrine infusion to maintain systolic blood pressure above 90 mmHg. C. Infuse normal saline intravenously at 100 mL per hour. D. Initiate an insulin drip to regulate blood glucose between 110 and 150 milligrams per DL. So let's go back into the case scenario here. There's so much going on. Low blood pressure of 72/45, 140 beats per minute. Respiration is so high, and there's fever, and there's also hyperglycemia. So which one would you address? Which one of the orders you should carry out here? Well, what is going on here is that the client is in septic shock. All right, I don't want to distract you here, but the case is on septic shock, which is a critical condition caused by a severe infection that is causing widespread inflammation. There is widespread vasodilation because of the chemical mediators. It's causing increased permeability of the blood vessels. So fluid from the blood vessels are actually seeping into the walls. It's gonna go into the interstitial spaces. So there is third spacing, and that is why there is hypotension, right? And so the body is struggling to maintain adequate blood flow and oxygen to the vital organs. And so your priority for this patient is to administer the IV fluids, and that's no other than letter C. Okay, you need to stabilize the blood pressure this time, especially that is already identified. And take a look into the 140 beats per minute. This is a compensatory mechanism due to the decreased blood pressure. All right, there is hypoperfusion, there is hypovolemia because of the third spacing. Now, this is very important because once the fluids is started, this will now restore the intravascular volume. It will increase the preload. It will also improve the perfusion to the vital organs, but it doesn't stop there, okay? So, according to the sepsis bundle, this is typically going to be treated by the use of the crystalloids like normal saline. And this is the first step that you should be doing to help stabilize the client, especially in septic shock. All right. So the normal saline of 500 mL per hour is an appropriate initial rate to rapidly expand the intravascular volume and to also restore the circulation. And this is very critical for improving the patient's overall hemodynamic status. Now, why is letter A incorrect? Tylenol, 650 milligrams. This is intended to reduce the fever. Well, this is not the first priority in managing septic shock. The reason this is incorrect is that reducing the fever does not address the immediate hypotension and poor perfusion. Okay, what you need to do here is to correct the circulatory issues through the use of the IV fluids and possibly vasopressors. So your focus should not be on the temperature management this time. Okay, you can administer the antipyretic once you have started your fluid replacement. All right. Now, what about letter B? Begin norepinephrine infusion to maintain systolic blood pressure above 90. This is incorrect. Remember about what I said earlier about norepinephrine. This is something that can cause vasoconstriction, right? This can increase the blood pressure, which is important in treating the sepsis or septic shock. We know that this is very critical to raise the blood pressure, but this is not the first step, okay? if you are going to administer this, and if there is hypovolemia, if there is third spacing, this is just going to cause vasoconstriction, but it will not cause, this will not really improve the perfusion. All right. You should address the volume deficit first before you administer the norepinephrine. Okay. Let me restate that. If you administer the norepinephrine first without the replacement of fluids, this can only cause vasoconstriction, and this will further cause organ damage because there is a lack of fluid volume. Okay, you need to restore and stabilize the circulating fluid volume because of the third spacing. Now, why is letter D incorrect? Initiate an insulin drip to regulate blood glucose between 110 and 150 milligrams per DL. So take a look here. The 260 milligrams per DL, it's high, but what we want to do here is to address first the hypotension, which is severe. We know that hyperglycemia is also common in septic patients, right? But tight glucose control with insulin is not the priority intervention in septic shock. What you need to do here is to stabilize the fluid circulation first, okay? You need to address the circulatory deficit. We want to address the hyperglycemia by administering the IV insulin, right? Or using the insulin drip once you have initiated the fluid replacement. And I want you to go back into my previous discussion regarding the diabetic ketoacidosis and the hyperglycemic hyperosmolar syndrome. I've discussed in depth regarding the treatment of the complications. So if you haven't watched that video, then I encourage you to look for that episode. So your test-taking strategy in this test question is to prioritize life-saving interventions. Is 260 milligrams of sugar really that critical? No, it's not that high yet. If you are worried about diabetic ketoacidosis, you're going to be worried about that when it reaches around the levels of 300, 400 milligrams per DL. Or if the client has type 2 diabetes, you're going to worry more about this when their blood sugar is greater than 600 or 800 milligrams per DL. So it's not as critical compared to what we have in letter C. Okay, we need to, or the blood pressure that is 72/45, and we need to replenish first the decreased circulating fluid volume because of the third spacing. Let's have number 34. A patient being treated for high blood pressure with furosemide, Lasix, atenolol, tenormin, and ramipril, Altase develops second-degree heart block, Mobitz type 1. What should the nurse prioritize in response? A. Prepare for cardioversion. B. Administer a 250 ml fluid bolus. C. Withhold the atenolol. D. Set up for an arterial line. The answer here is letter C. And why is that? Well, take a look into the scenario one more time. Originally, the patient is hypertensive, right? The patient is treated with high blood pressure medications. There's atenolol, there's ramipril, and also Lasix. But then the client has now a complication developing into second-degree heart block, Mobitz type 1. So what you need to evaluate here are the effects of the drugs. Okay. So the patient's treatment regimen is something that you should focus on this time. Now, the client's medications such as Lasix, we have a diuretic, we have a beta blocker, that's tenormin, and we have Altase, the ACE inhibitor, right? Now, pointing into the beta blocker right here, this is a drug that blocks the beta adrenergic receptors, particularly in the heart. So, go back to the atenolol. This blocks beta receptors in the heart. And the end effect here is going to be slowed heart rate. Okay. And this can also reduce the conductivity through the AV node. So that's another issue. Reduced conduction of impulses to the AV node. So these are the things that can happen as a complication to the administration of the atenolol. Again, it's a beta blocker. It can also decrease the conduction of impulses to the AV node. And again, this can exacerbate a conduction delay, particularly in this case, right? And so with the development of the heart block, the electrical signals are delayed progressively until one signal is completely blocked. Now, if a patient is already at risk for this, a beta blocker like atenolol could worsen the situation by further delaying the conduction. And so the priority intervention here is to withhold the atenolol to prevent further slowing of the conduction. Now, why is letter A an incorrect option? We're talking about cardioversion in letter A. Well, this is not appropriate response because cardioversion is used for more severe atrial arrhythmias like fibrillation and ventricular tachycardia. Again, this is indicated for VTAC, also atrial fib. That's going to be the indicators for the cardioversion. And Mobitz type 1 heart block typically doesn't require the cardioversion, especially if the patient is asymptomatic. Now, what about letter B? Administer 250 ml fluid bolus. Well, take note that this is something that you will be seeing as part of the order in cases like shock, or if there is dehydration or there is hypotension, but there is no indication that the patient has these conditions. So also, the furosemide is more likely to deplete the fluid volume, which could complicate the situation, not improve it. And so there is no correlation with this treatment. So eliminate that one. Now, what about letter D? Set up for an arterial line. Of course, this is already incorrect, right? But what is the reason for that? Now, again, back to the arterial line. This is going to be used as a means for monitoring the blood pressure continuously using that radial artery or femoral artery, and this is used in critical care. But there is no indication in the question that this patient is experiencing these issues. And so setting up an arterial line this time is unnecessary. And so your strategy in answering this question is to focus on the patient's medication regimen, also understand the drug action and the possible complications. And in cases like this, you have to go back into the effect of the beta blockers and how this can affect the conduction. All right. So you have to always prioritize the interventions that directly address the underlying cause of the problem. And you got to be cautious about medications that might exacerbate the condition because of the what we have in our case, the atenolol. All right, let's have number 35. While assessing the competency of a newly hired RN in managing patients with different types of shock, the nurse educator identifies which action as requiring additional training. Options: A, adjusting the nitroprusside infusion rate upward for a patient with significantly elevated systemic vascular resistance. B, positioning a patient with hypovolemic shock in a supine position. C, using an ear probe pulse oximeter for a patient diagnosed with septic shock. And D, keeping the patient's environment cool for a patient with a neurogenic shock. The answer is letter D, keeping the patient's environment cool for a patient with neurogenic shock. All right. Why is this the answer? Well, going back into the concept of neurogenic shock, This is something that can happen when there is a disruption in the autonomic nervous system. ANS disruption. Okay. And this can lead to vasodilation and hypotension. And one of the key features of the neurogenic shock is the poikilothermia. So what does that mean? Poikilothermia. This simply means that the body can no longer regulate the temperature effectively, and this will lead to the patient becoming hypothermic. That is the risk of the poikilothermia. And with the client that has neurogenic shock, you have to maintain a warm environment for the patient. You got to keep them in a that environment, because if you're going to keep them in a cool environment, this could lead to further hypothermia, which can exacerbate the client's condition. Now, the other options here, so for example, letter A, adjusting the nitroprazide infusion rate upward for a patient with significantly elevated SVR. We know that the nitroprazide is a vasodilator that is used in shock state to reduce the afterload, which is the systemic vascular resistance, and to improve the cardiac output. Now, in patients with elevated SVR, nitroprazide is typically used to lower SVR and improve the perfusion. All right. And so this is supposed to help decrease the resistance the heart must work against to allow for better blood flow and improving the overall circulation. And so this action does not indicate a need for an additional training, because this is a standard intervention for managing an elevated stroke systemic vascular resistance in the shock. All right. So what about letter B? Why is this incorrect? Positioning a patient with hypovolemic shock. Well, in hypovolemic shock, the patient has significant fluid loss, and this can lead to decreased circulatory volume and low blood pressure. And the supine position is recommended because in these cases, it helps to optimize venous return to the heart, improving the cardiac output. And also, this can also maintain circulation, which is vital in the hypovolemic shock. And this is also an appropriate action. And there's no further training that is required here. Now, what about letter C? Using an ear probe pulse oximeter for a patient diagnosed with septic shock. Well, this is going to help in measuring the O2 saturation in the blood in this case. And since they often experience hypoxia, this is also a good intervention. So this is also a good alternative in cases where there is going to be a challenge in the peripheral circulation, wherein you might have difficulty in obtaining a oxygen saturation through the finger. And so this is also an acceptable and often accurate method of assessing oxygen saturation in septic shock. All right. Now, for you to answer this question correctly, I want you to focus on the specific type of the shock. And the key to this question is recognizing the type of shock the patient is experiencing and understanding the associated physical changes. And so for this instance, we have a neurogenic shock in option D. Temperature regulation is critical. All right. Let's have number 36. In a patient who has a pulmonary artery catheter inserted, which of the following measurements is obtained when the catheter is inflated and wedged in a pulmonary artery branch? I've shown you this in our previous item about the pulmonary artery wedge pressure. Options: A, left ventricular and diastolic pressure, B, cardiac index, C, cardiac output, and D, right atrial blood flow. So it's asking which of the following measurements is obtained when the catheter is inflated and wedged in a pulmonary artery branch. Remember about that balloon that was inflated? the catheter is passed through from the right atrium, passed through the tricuspid valve, to the right ventricle, to the pulmonary artery, and then to the distal end of the pulmonary artery. And so when it says wedged in the pulmonary artery branch, it's basically causing that temporary occlusion, right? And so this is going to cause that value to appear in the screen. So this is basically the left ventricular and diastolic pressure. And so when the balloon of the pulmonary artery catheter is inflated, and when this is lodged into the distal portion, it will occlude the vessel and it will indirectly measure the left ventricular and diastolic pressure. And this is also what we refer to as the pulmonary artery wedge pressure. So they are synonymous. Wedge pressure. And so the balloon's inflation can cause the pressure to reflect the left side of the heart, specifically the left ventricle during the diastole when the mitral valve is open. And the left ventricular and diastolic pressure will provide you the information about the left ventricular function and the filling pressures, which are very critical for assessing heart failure, or let's say if in a case of a fluid overload. And so when you encounter this type of question involving a pulmonary artery catheter and wedge pressure, you should immediately think about LVEDP, okay? Or the pulmonary artery wedge pressure, because this test is primarily used to evaluate the left side heart function, okay? And also this will help understand the mechanics of the wedge position, which will help guide you to the correct answer. Okay, now why is letter B incorrect here? Cardiac index. Well, the cardiac index is calculated by dividing the cardiac output by the body surface area. Cardiac output divided by the body surface area. So this is going to be used to assess the cardiac output in relation to the patient's body size. So it is not directly measured by the pulmonary artery catheter. And as we are talking about the pulmonary artery catheter, this can measure the pressures but does not directly calculate the cardiac index. The catheter can also provide useful data on the heart performance, but not in the form of the cardiac index, because you need to have the BSA here. Okay, so this is basically obtained through the calculation rather than a direct measurement. And so whenever you see a ratio like cardiac index, you got to consider whether the device described in the question directly measures that value. But in this case, the pulmonary artery catheter does not measure cardiac index. What about cardiac output? Why is this incorrect? Well, we know that cardiac output is the total amount of blood that the heart pumps per minute, and it can be measured using methods like thermodilution or the Fick's method. Okay, so this is going to be measured by Fick's method, but we're not gonna do this in depth here. And so the pulmonary artery catheter does not directly measure the cardiac output through the wedge pressure. Okay, the pulmonary artery catheter can be used to measure the pressures in the heart, including pulmonary artery pressures, and sometimes it can indirectly aid in assessing the cardiac output, but it does not directly measure the cardiac output. What about letter D, right atrial blood flow? Why is this incorrect? Well, the pulmonary artery catheter is used to measure the right atrial pressure. That's the RAP. Okay, right atrial pressure, not atrial blood flow. That's two different things. Okay, so the RAP is going to reflect the pressure in the right atrium, and this is helpful in diagnosing conditions like right-sided heart failure. Okay, so helps diagnosis of right-sided heart failure. However, the catheter, the pulmonary artery catheter, does not provide direct measurements of the blood flow in the right atrium. And so when you're going to encounter this type of test question, and you have to pay attention to the term here, wedged. All right, that is the clue right there. This is pertaining to the catheter that is wedged in the pulmonary artery branch, and it is going to indirectly measure the left end, or the left ventricular end diastolic pressure, or what we call as the pulmonary artery wedge pressure. Okay, and so you're going to eliminate those options that refer to measurements that do not relate to the function of the pulmonary artery catheter. So in this case, you got to eliminate the cardiac output because the pulmonary artery catheter doesn't measure that. Same thing with the cardiac index, and it doesn't also measure the right atrial blood flow. Alrighty, let's have number 37. A nurse is monitoring a patient diagnosed with septic shock. Which assessment finding requires the most urgent notification to the healthcare provider? Options: A, blood pressure measuring 92/56. B, oxygen saturation of 93 on room air. C, heart rate of 118 beats per minute. D, skin that feels cold and moist to the touch. The answer here is letter D. And why are we going to select letter D? About integumentary manifestation. Well, going back into the septic shock, the body is going through the phases of the vasodilation, right? It can lead to impaired tissue perfusion. Now, let's go back into the early stages. The patient will often present with warm, flushed skin due to the peripheral vasodilation. So let's emphasize this: early septic shock. So what you're going to see in the early stages, there's going to be warm, flushed skin. And why is that? The reason for that is because there is a peripheral vasodilation, which is a compensatory mechanism. All right? This is a normal occurrence. Peripheral vasodilation. That's why the skin will look kind of red or flushed. And the reason for this is to allow more blood to reach the skin surface. And the body is trying to redirect the blood to the vital organs. However, when the shock progresses, okay, there is going to be that later stage of shock. So the compensatory mechanisms will start to fail, and the patient will now show signs of poor tissue perfusion. So from being warm, flushed skin, this is now going to lead to clammy. There's going to be moist skin. And the reason for that is because of the vasoconstriction. All right? And this is a sign that the blood flow to the skin is reduced. And there is now worsening and of the patient's sepsis, and the perfusion is not being maintained properly, which is indicative of critical deterioration of the septic shock. Okay, so the cold, moist skin is a late sign of shock, and this suggests that the body's compensatory mechanism is actually failing. All right, so you need to immediately notify the medical provider about this, because this will need prompt intervention to improve perfusion and also to prevent multi-organ failure. Now, why is letter A incorrect? Blood pressure of 92/56. This is low blood pressure, which is a common finding in septic shock, and it indicates hypotension. It's a hallmark, right? However, the goal in septic shock is to maintain the systolic blood pressure above 90 mmHg. And the current reading is 92/56, which is borderline and still within an acceptable range for some patients. We know that low blood pressure requires attention, but it is not as critical compared to the cold, moist skin, which suggests that there is already worsening perfusion. And what you can do with letter A is that you can address this by administering fluids, vasopressors, and other interventions, but this is not as urgent in this specific scenario compared to what we are seeing in cold and moist to the touch sensation. Now, letter B, oxygen saturation of 93 on room air is also low. This is also, the oxygen saturation is basically the crucial indicator in septic shock. And this level, while the patient is in room air, is not alarmingly low, even though you need to monitor this patient. But most patients can tolerate oxygenation between 92 to 94% on room air, especially in the early stages of shock. And this finding does not suggest acute deterioration. And in the context of the other options, this is less urgent than the cold, moist skin, which points to a critical stage in the shock. That's why it is incorrect. Now, letter C, heart rate of 118 beats per minute, reflecting tachycardia, is also expected in septic shock because of the body's attempt to compensate for the low blood pressure and poor tissue perfusion. But this is also expected to maintain the cardiac output. We know that this is going to require monitoring, of course. We don't neglect this, but this heart rate is not a red flag in itself, and this can be managed with fluid resuscitation and other supportive measures. So the cold, moist skin is still a more urgent finding. It indicates that the client is in a severe stage of shock already. So for you to answer this question, I want you to prioritize findings that suggest worsening. We have this clue right here. Requires the most urgent notification. All right. So I want you to look for the clues in this type of shock. And again, we are talking about septic shock, which typically presents with warm, flush skin early on. But if you notice a patient developing cold, moist skin, there is that progression to a more severe shock. And this should require your immediate action. Let's have number 39 rather. Do we have 30? Oh, did I skip? 39. A patient with myocardial infarction develops cardiogenic shock and an arterial line is placed. Which of the following orders from the healthcare provider should the nurse clarify before proceeding? Options. A. Adjust the Dobutamine Dobutrex infusion to maintain a systolic blood pressure greater than 100. B. Administer metoprolol Loprazor 5 milligrams IV push. C. Prepare the patient for a pulmonary artery catheter insertion. D. Notify the provider if urine output is less than 30 mL per hour for 2 consecutive hours. The answer is letter B. Take a look into the question stem. Which of the following orders from the healthcare provider should the nurse clarify before proceeding? This is the huge clue. All right. So why is letter B the correct answer? Metoprolol, 5 milligrams IV push. We know that this is a beta blocker, and this is often used to reduce cardiovascular mortality in patients with hemodynamically stable patients, I should say, in acute MI. However, when the client develops cardiogenic shock, this is the factor. When the client has cardiogenic shock, the patient is in a hemodynamically unstable state. Remember what I said earlier about beta blockers? They're not supposed to be given to patients in an unstable state. All right. You can administer the beta blockers when the heart failure manifestations have been stabilized. Right. So the client in this scenario is hemodynamically unstable because of the cardiogenic shock. I want you to remember this about beta blockers. All right, that's a critical component concept about the administration of beta blockers. All right, so when you administer the metoprolol, especially in this case with a cardiogenic shock. This will reduce the heart rate all the more because it is going to block the beta receptors in the heart, right? Another thing that it can do, it will decrease the contractility. And remember that the main issue in cardiogenic shock is decreased contractility. We don't want this happening, all right? We want to stabilize the patient first. We want to improve the force of the myocardial contraction. And that is why you have to question the order of administering metoprolol, all right? So when you're dealing this type of cardiogenic shock, you have to critically think about how drugs impact the heart function. Again, the beta blockers can exacerbate the hypotension. It can decrease the contractility. It can also decrease the cardiac output. We don't want this either. All right, so this is our best answer. Now, why is letter A incorrect? Adjust the Dobutamine Debutrex infusion to maintain asystolic blood pressure greater than 100. So Dobutamine, as a review, this is a positive inotropic drug. When I'm talking about inotropic effect, this is going to help increase the contractility of the heart muscle. And this is what we want in cardiogenic shock. We want to strengthen the muscle contraction in order to improve the pumping mechanism, all right? And when you are adjusting the dobutamine to maintain a systolic blood pressure greater than 100, with a treatment goal, this is consistent, right? It's going to help improve perfusion. It will prevent further organ damage. And so this order is appropriate. You do not need clarification for this medical order. So eliminate this one. Now, what about letter C? Prepare the patient for a pulmonary artery catheter insertion. Is this going to be appropriate? Well, we know that the pulmonary artery catheter is going to help measure the pulmonary artery wedge pressure, can also indirectly do the calculations. And this is going to help assess the fluid status as well. So this will guide the treatment in the treatment of the cardiogenic shock. And this is also an invasive procedure that will help give you valuable information about tailoring the therapy, such as fluid management and also the administration of the medication. And in the case of cardiogenic shock, this is going to help you understand how the heart is functioning. And this is also, and preparing the client or preparing the patient for a pulmonary artery catheter insertion will also be appropriate. So you're going to discard this one as well. Now, letter D, notify the provider if urine output is less than 30 mL per hour for 2 consecutive hours. Yes, that is a good action, right? Notification, especially when the urine output is compromised, is basically a nurse that is quite using their brain, right? And so you are assessing directly the kidney function, especially in this patient that has cardiogenic shock. We know that the kidneys may be compromised due to the inadequate blood flow, and there is going to be a reduction in the urine output. And so if you are the nurse notifying the healthcare provider that there is low urine output, then this is a sign that you are really watching your patient. The patient has renal hypoperfusion, and this is appropriate as well. So when you are going to answer this type of question, you got to pay attention to what it's really asking. So we are looking for that action we are looking for that item that will require clarification. All right. So you are going to eliminate those answers that reflect good nursing actions. Let's have number 40. A patient arrives in the emergency department following a diving accident and is suspected of having neurogenic shock. A cervical collar is in place. Which actions should the nurse prioritize? Select all that apply. Options: A, Provide 100% oxygen via a non-rebreather mask. B, administer atropine intravenously. C, administer large amounts of lactated Ringer solution. D, measure baseline body temperature. E, prepare for possible intubation and mechanical ventilation. We have a select all that apply question, and the answers are letters A, B, D, and E. Now, why is letter A one of the correct options? Well, because one of the primary issues in neurogenic shock, we're talking about this one, is impaired circulation, and there's also impaired oxygenation. And why is that? The sympathetic nervous system is compromised with neurogenic shock, and this can lead to poor tissue perfusion. There's also poor oxygen delivery to the vital organs. And with the administration of a high flow O2 supplement such as non-rebreather mask, this is very critical in order for us to ensure maximum possible oxygen to help prevent hypoxia and to improve the tissue oxygenation. So whenever you're going to see a shock, especially neurogenic shock, you got to think about oxygenation first. This is critical. This is going to affect the sympathetic nervous system. All right. What about letter B? Administer atropine intravenously. What is the role of atropine here? Remember that in neurogenic shock, there is loss of sympathetic tone, and this can lead to bradycardia. All right. So there is loss of sympathetic tone. So there is going to be bradycardia. And remember what the atropine can do. The atropine can help that because the atropine can block the parasympathetic effects. This can lead to an increasing heart rate, which is necessary to maintain adequate cardiac output and also the perfusion. And so this is also an appropriate treatment to manage the bradycardia and to improve the perfusion. Okay, so don't forget about the loss of sympathetic tone in neurogenic shock. Now, what about letter D? Measure baseline body temperature. Remember about what I said in the previous item about neurogenic shock, that with sympathetic nervous, that whenever there is neurogenic shock, there is also loss of the sympathetic tone that can result in poikilothermia. Okay? Remember what I had stated earlier. Poikilothermia. So here, the body will have the inability to regulate the body temperature. And this means that the body might become too cold or too hot, depending on the environment the patient is in. And so when you're measuring the baseline temperature, you can detect any abnormal temperature changes, and this can help in planning your treatment as well. Okay. And what about letter E? Prepare for possible intubation and mechanical ventilation. Why is this appropriate? Now, in severe cases of neurogenic shock, this can lead to respiratory depression or failure, especially when the brainstem function is affected. And we know that the brainstem is basically responsible to control the respiratory centers. Okay. So basically, this is going to regulate the respiratory center. And if there is going to be a problem in the brainstem, this can lead to inadequate ventilation. So you got to be prepared for the intubation here and mechanical ventilation. So you got to monitor the client's respirations, their breath sounds, and you got to be proactive in case the patient's condition worsens. And so you have to look for any respiratory signs, let's say slowed or maybe irregular breathing, especially in this neurogenic type of shock. And especially that the client has this This is basically your clue here as well. Cervical collar is in place. So it could also lead to cervical injury, which might impair the function of the phrenic nerve. So that's another factor. So that is another clue that the patient may need advanced airway management. So always be prepared. Now, why are the other incorrect options? So we have letter C, which is administer large amounts of lactated Ringer solution. Now, why is this incorrect? Well, we know that in many types of shock, fluid resuscitation is critical. But in neurogenic shock, the client usually has normal circulating fluid volume. Okay, so they do not require large amounts of fluid replacement. And if you are administering large amounts of LR, this is going to cause fluid overload. Again, the client does not have an issue with fluid loss. So your patient now will be at risk to developing fluid overload. They do not require fluid resuscitation here. Okay, that's something that you should keep in mind. So what you want to do here in this type of question, I want you to pay attention to the type of shock that we are experiencing in this client. Neurogenic shock. Okay, in neurogenic shock, fluid overload can be harmful because the blood volume is usually adequate. And so always think about fluid management based on the patient's specific condition. And I want you to avoid actions that contradict this. So excessive administration when not needed could harm your patient. So my strategy for you to use in this question, I want you to identify first what the shock is all about. Is it neurogenic? Is this hypovolemic? Is it septic? Again, this is neurogenic shock. This is going to primarily affect the sympathetic nervous system, and this should help guide you in choosing your interventions such as oxygenation, the heart rate, as we know that with the neurogenic shock it can cause bradycardia, and also you need to manage the temperature regulation and also respiratory support, possible intubation because of the possible injury to the cervical spine, which could compromise their airway as well. And so you have to avoid those unnecessary actions that do not match the patient's condition. And again, that is letter C. All right, so that wraps up today's NCLEX art and review on hemodynamic management. So we have covered those critical topics like CVP, the mean arterial pressure, the cardiac output, shock management, hemodynamic monitoring, and also vasoactive medications, which are all critical in recognizing and also responding to the cardiovascular instability in the case scenario. So I want you to always assess for the perfusion indicators like MAP, urine output, and the mental status. And you got to know your numbers as well. The CVP, the pulmonary artery wedge pressure, and the cardiac output. And always think about the fluids versus pressors. So you have to understand when fluid volume expansion is needed versus vasopressors like dopamine or norepinephrine or dobutamine. And think about the use of the inotropic agents such as the cardiac glycoside. We have the digoxin versus the dobutamine, especially in the different stages of the heart failure. So you have to recall those as well. And think about the trends, not just single values, because hemodynamics is about ongoing assessment, not one-time readings. And so the more NCLEX-style questions that you tackle, such as these, the more confident that you'll be in real life and when you are taking the NCLEX as well. And so if you have any questions, kindly drop them in the comments. So let's keep the discussion going, and I hope that I can support you more as you are trying to pass for your NCLEX. and to become as an amazing nurse. So until next time, keep learning, stay confident, and trust your clinical judgment. Thank you.